الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. السلام عليكم welcome everybody. First of all, I have to thank all of you for attending our course, and hope it will be an interesting for all of you. As you know, the course is about emergencies in medicine, and the common scenarios. We'll try to discuss these scenarios over the coming 3 days, starting from today. And we know that the dealing with the emergency cases will be difficult if you don't have the knowledge base. And to discuss this knowledge base and try to give some hints in the practical management, we'll try to focus on the common medical emergencies, which will be covered for all of the we can say chapters and systems related to internal medicine, like, for example, endocrinology, cardiology, rheumatology, gastroenterology, etc. With no further delay, I will start with the first topic, which is about diabetes emergency. And this is a reminder, or this is an announcement for all of you. If you are interested in diabetes and endocrinology, please follow our Twitter account, ENDODMOS, ENDODMOS. This is a pure scientific account about diabetes and endocrinology. So if you are interested, please follow this account. It's a pure scientific account about update in this field. So we know that the emergency, it covers, or diabetes emergency, it covers both DKA and hyperosmolar non-ketotic status. And this is the aim of our topic here, to discuss these two roughly. We know that diabetic ketoacidosis, insulin deficiency and dehydration, and the other one about hyperosmolar non-ketotic status occur usually in diabetic patient. The first one is more common in type 1, and the second one is more common in type 2. And we know part of diabetes care and management that you have to cover the acute complications, to identify what are the causes and what are the protocols, and to educate the patient and staff how to deal with these diabetes cases. Who are the patients at risk to develop diabetes emergencies? We have many examples. And the first example here is, for example, patients who are elderly, patients who are very young, patients who are using, for example, substance abusers with cognitive deficiency, patients on polypharmacy, and patients who are using insulin because it is easy to miss these doses of insulin. So please keep it in your mind that maybe it is difficult to deal with these patients because they are more prone to go for diabetes emergencies. So what do we have more? These are the factors that affect the blood glucose, as we mentioned. So keep it in your mind. You have to concentrate and to know about symptoms of hyperglycemia. For example, thirsty, hunger, increased urination, fatigability, vision changes, and vague malaise. These are the symptoms of hyperglycemia. So please, if the patient presented an emergency with these symptoms, where a patient known to have, or even patient suspected to have diabetes from the history, please, it is very important to go for blood sugar measurement, followed by investigations that rule out diabetes emergency, as will be mentioned in few slides. So acute hyperglycemia leading to crisis, low level of circulating insulin, high level of counter-regulatory hormones, resulting in ketoacidosis, or what is called DKA, and hyperosmolar status, HHS. So this is a quick question for the audience. A patient may has normal blood glucose and still you can diagnose diabetes ketoacidosis. So what do you think this statement is true or false? I need your participation, please, down in the chat box. So is it true or false? So let's discuss the answers down in the chat box. Yes, true. Excellent. Maybe sometimes we can diagnose patient with diabetic ketoacidosis with blood sugar normal. Why and how? What are the cases? The cases, for example, if the patient are using euglycemic or sorry, patient are using drugs that may lead to euglycemic DKA. For example, for example, SGLT2 inhibitors. So sodium glucose transporter 2 inhibitors users, we know the mechanism of this drug to take down the blood glucose in the urine from the bloodstream. And by this way, we know it is obvious that blood sugar in the blood, yes, blood sugar may be normal, but patient has characteristic lab for acidosis because of this drug. So this is number one differential diagnosis. The other one, pregnant ladies also may present it with the same scenario. Maybe they have euglycemic DKA. Euglycemic means blood sugar is normal and there is diabetes ketoacidosis. And the third one, if the patient they are using alcohol, if some patients are using alcohol, so maybe this is another differential diagnosis in which we are seeing patient with normal blood glucose and patients still diagnosed with diabetes ketoacidosis. So please keep it in your mind that this is the differential. What are the precipitating factors for diabetes emergency? For example, if the patient missing the dose or omitting the dose of insulin, um, if the patient using acute major illness such as myocardial infarction, cerebrovascular accident, sepsis, or pancreatitis, if the patient drugs using steroid, if the patient using steroids, high dose of thiazide diuretics, sympathomimetic agents, and atypical antipsychotic agents. All of these are differential diagnoses of hyper or diabetes emergency. So patient, they are using all of these. Maybe they are a risk factor. They are at risk to develop diabetes ketoacidosis or, for example, HHS, and using GLT2 inhibitors like empagliflozin, dapagliflozin, and canagliflozin, psychological problems, cocaine abusers, and insulin deficiency, for example, patient using pump and they are missing the doses because of the malfunction or kinking in the set, etc. What about diabetic ketoacidosis? Diabetic ketoacidosis is an acute, severe metabolic complication related metabolic complications characterized by acidosis in the blood and hyperglycemia. Hyperglycemia. It is more common to see diabetes ketoacidosis in type 1, type 2, and GDM. So I need your interaction, please. What do you think? A, B, or C? Excellent. Excellent. Your participation, yes, majority or commonly more to have DKA more in type 1 diabetic patients. So what are the differences that may be seen in patients with both in diabetic ketoacidosis, which is more common in type 1, and hyperosmolar non-ketotic status, or what is called HHS in type 2. Type 1 diabetic ketoacidosis onset is 24 hours or less. This is the usual. It's quick and observed acutely. It is associated or some manifestations are seen like dehydration, tachycardia, hypotension, acetone breathing, osmorespiration, and mental status range from alert to stuporous. So this is what we are observing in type 1. Let us go for type 2, who are presented usually or more commonly with HHS. Usually the onset is gradual, days to weeks, and also we can observe profound dehydration, tachycardia, hypotension, focal neurological symptoms, maybe some patient presented with a stroke, and they are losing, or there is, for example, paralysis, hemiplegia, sometimes observed. Mental status changes all up to coma can be seen or observed. What are the differences in the lab? Usually, this is a common schedule to differentiate between the two. Plasma glucose usually above 600 in hyperosmolar, but usually above 250 in DKA. Plasma glucose arterial pH can see in HHS usually more than 7.3, but usually there is low pH, which is associated with metabolic acidosis in DKA. And we know there are subcategories of DKA, mild, moderate, and severe. In mild, 7.25 to 7.3, and in moderate 7 to 7.24, and in severe cases, we have a very low pH, which is less than 7. What about the serum bicarbonate? In mild, we have level between 15 to 18, and in moderate between 10 to 15, and in severe cases less than 10. What about hyperosmolar? HHS, it is usually above 18. Ketone urine usually positive in all cases or subcategories of DKA, and randomly sometimes maybe due to dehydration we observe urine ketones positive in HHS. Serum ketones also may be positive or it can be detected positive in DKA, but of course it is not detected in HHS or very small. What about the anion gap? Usually we have high anion gap metabolic acidosis in cases of diabetic ketoacidosis. It is defined above 12 usually, but in HHS usually there is no anion gap. And as we mentioned before, the sensorium or the level of consciousness may be up to coma is lost. So this is what we are observing here. In summary, what are the lab manifestations in these two diseases? And I mentioned before that we have subcategories of DKA, mild, moderate, and severe, and why it is important to classify your DKA into mild, moderate, and severe, because we know that severe cases Maybe if pH less than 6.9, you have to give sodium bicarbonate, or maybe you can give sodium bicarbonate also as IV infusion if we have very low sodium bicarbonate level in the blood. What is the management of DKA? The current treatment guidelines, HHS require hospital admission for intensive hydration and glucose management. DKA home intervention to prevent progression, hydration with non-caloric and caloric fluid, insulin correction dose, close monitoring of glucose and urine, hospitalization for ketones, more and moderate or disease progression. So it is obvious that we can see the treatment guidelines differs slightly between these two categories, but it is observed easily in the current guidelines. I mean, commonly we are seeing the same characteristic, but some differences are there. So what are the headlines? Number one, replacement of fluid loss, correction of hyperglycemia, metabolic acidosis, replacement of electrolyte loss, detection and treatment of precipitating causes. Markers of severity, as we mentioned, sometimes patient need management in ICU. Not sometimes, usually, actually, we need to deal with DKA cases in ICU. But as we mentioned before, in severe cases, it is more critical to deal with them. pH less than 7, bicarb less than 5, potassium less than 3.3, or more than 6, systolic blood pressure less than 90, saturation less than 92, urine output less than 0.5 ml per kg per hour, Glasgow Coma scale less than 12. What is the immediate management in these immediate management if patient presented in emergency, intact airway, breathing and circulation, you have to check. This is maybe the first point. And attach your patient to cardiac monitor, urinary catheterization, very important. Consider central venous pressure measurement with central venous line, nasogastric tube if there is a necessary point. What about monitoring? Vital signs hourly, cardiac monitoring, urine output hourly are very important. So we know that the management of DKA and hyperosmolar non-ketotic status need infusion to be connected, and this is including insulin. So the question here, which type of insulin you will fill your pump or infusion set in cases of emergency, diabetes emergency. You will fill it with regular insulin, glargine, or detemir. I need your excellent income, yes. Input from your side, yes, regular insulin. This is the usual type of insulin. Maybe sometimes use rapid-acting insulin like Aspart and Lispro also. The protocol for management of adult patient with the diabetes ketoacidosis also is observed here. you see that we have categories for involvement or to give treatment into the following. You will give IV fluid, you will give potassium, you will give insulin, you will give bicarbonate if needed. So as I mentioned before, pH usually less than 6.9, maybe you give intravenous sodium bicarbonate. And the IV fluid usually determine volume status is your first step. And then you can administer the type, the proper type of IV fluid, like sodium bicarbonate, for example, normal saline, if the patient has severe hypovolemia. In mild hypovolemia, maybe you have to address the sodium status, serum sodium status, and if the serum sodium status determine hydration status next is your guide. And maybe if the patient has serum sodium high, you have to go for half normal saline is the proper fluid. Usually the fluid here 250 ml per hour, and then you can reassess according to the situation. Even the serum sodium is normal, you can go with this approach. But if the serum sodium is low, 0.9% or normal saline is the administered or preferred fluid, again with 250 ml per hour, and then you can observe the urine output, and you can determine, you can change the fluid also. If the patient, for example, reaches 200 milligram per deciliter, change to 5% dextrose. Why? To prevent any hypoglycemia. And if the patient is shocked, definitely hemodynamic stability with inotropic support plus fluid is your goal. What about the potassium? A very critical point to know that if the patient has hypokalemia, don't give insulin or don't start insulin infusion, because maybe it leads to more deterioration in the potassium level. And the serum potassium in this status, as you can see here, is will be deteriorating. So before starting, or it is very important to check potassium level in the beginning. If it is less than 3.3, hold insulin and give 20 to 40 milliequivalent potassium per hour until potassium is increased above 3.3. If the serum potassium between 3.3 to 5.3, give 20 to 30 milliequivalent of potassium in each liter of IV fluid to keep serum potassium between 4 to 5. If the serum potassium is more than 5.3, don't give, and monitor the blood potassium every 2 hours. What about the insulin? Insulin, as we mentioned, it should be given intravenously through insulin infusion pump. Sometimes if we have mild DKA, maybe you can use subcutaneous insulin, rapid-acting insulin, 0.2 unit per kg per hour. The insulin infusion is the preferred way, and the usual dose is 0.1 unit per kg as bolus in the start, and then you can give the infusion 0.1 unit per kg per hour. If the serum glucose does not fall by about 50%, 50 milligram per deciliter in the first hour, double the dose of intravenous or subcutaneous insulin infusion. When serum glucose reach 200 milligram per deciliter, reduce regular insulin infusion 2.02, 2.05 unit per kg per hour, or give rapid-acting insulin at 0.1 unit per kg subcutaneously every 2 hours. Also keep serum glucose between 150 and 200 milligram per deciliter until resolution of DKA. Check electrolytes, very important while we are managing the diabetic ketoacidosis after resolution of DKA, and when patient able to eat, initiate subcutaneous multi-dose basal insulin of infusion. Continue intravenous insulin infusion for 2 to 4 hours after subcutaneous insulin begin. This is very important. If the patient is out of DKA, please give basal insulin before the insulin infusion stops. And there is what is called bridge or overlap period, which is about 2 hours. So in these 2 hours, insulin lantus, for example, or glargine should be started. And then after 2 hours, you can discontinue insulin infusion. By this way, you prevent any hyperglycemia, or at least to minimize the risk of hyperglycemia occurrence with missing or no insulin coverage. What about the resolution of diabetic ketoacidosis? We have some criteria. If the blood glucose normalized less than 250, serum bicarbonate started to be improving, which is the level usually above 18, venous blood pH improving above 7.3, and closed anion gap less than 12. This is a quick, we can say, review. What is the correlation between hemoglobin A1C and the blood glucose average? If the A1C, for example, is 7, the blood glucose range between 123 up to 185, and the estimated average is about 154. If the A1C, for example, is 10, estimated blood glucose will be 193 to 282, and the average is, for example, is 240. So this is how to correlate the blood glucose, how to correlate the blood glucose with the hemoglobin A1C if it is missing, for example, one of them. Well, if you discharge your patient after improving of DKA, you have to keep in your mind some target. Usually fasting blood glucose or 3 meals blood glucose should be between 80 up to 130. Postprandially, it is recommended to keep blood glucose less than 180, and at bedtime, it is recommended to keep it between 90 up to 150. A1C 2 to 4 times per year. This is the recommended how to check or how frequent to check. Less than 7% is your target. I will leave you with one of the videos to summarize what we have mentioned. So please concentrate in the coming few minutes about this video and this video.
Hey guys, Nurse Mike here, and welcome to SimpleNursing.com. Now, before we get today's lecture started, please remember to access your free quiz and preview our cool, nifty new study guides, not here on YouTube. Click the link right up here at any time during this video. All right, guys, let's begin. So how do you tell the difference between DKA and HHNS? Well, DKA is more common in type 1 diabetes and HHNS for type 2. So think which letter comes first in the alphabet. Well, guys, D comes first, so it's type 1, and H comes second, so that's how you know it's type 2. Now, what is DKA? Well, guys, let the name help you. Diabetic ketoacidosis. There is no insulin produced since it's type 1, guys. We have none. The body killed its own pancreas, and as usual, no insulin means no sugar in the cell. Therefore, the body must burn fat for fuel, resulting in fat waste, and ketone bodies are produced. Kind of like how a diesel engine blows off a lot of exhaust, ketone bodies are very acidic wastes. So we have high acid in DKA, or diabetic ketoacidosis. Now type 2, we have few insulins barely working, so HHNS or just HHS, let the name help you. So hyperglycemic, we have the higher sugar. Hyperosmolar, we have very thick dehydrated blood. Guys, huge dehydration here. And non-ketonic, we have no ketones, and S is for syndrome. Now, since the body has barely enough insulin to put sugar into the cell, while the body burns sugar for fuel, so we don't get those ketone bodies. So guys, think type 2, you have a few insulins working, so no fat burn, no ketones, since the body's burning glucose. Now, typically, DKA has a faster onset, and consequently, it's easier to fix. since the patients are young with type 1 diabetes. And HHNS is a slower onset with older patients. So guys, it's harder to fix HHNS. Now for the causes, DKA, remember the 3 S's like high sugar. So sepsis, like infection, guys, always an NCLEX favorite. The #1 cause of DKA is infection. Second S is for stress like surgeries or even skipping insulin. Guys, kids in type 1 will get the flu or an infection and then boom, end up in DKA. Or they'll go to surgery without increasing their insulin dose and then bam, DKA. And similarly, on the other side, older patients in HHNS commonly caused by illness and infections. So what are the main differences in the signs and symptoms? Well, for DKA, this is super hard, right? Just remember the acronym DKA. So D for a dried body, guys, and high sugar, 250 to 500 from the lack of insulin. Guys, that's a huge key word, 250 to 500 with type 1 diabetics. Now, K is for ketones and Kussmaul respirations, or known as fruity breath. Key words here for the NCLEX, deep, rapid breathing that smells fruity. This is called Kussmaul respirations, so think ketone respirations. So we say, ketones, do you love me? Are you riding? The body is in metabolic acidosis, so the body tries to correct itself, or basically compensate, and get rid of all this acid. It does it by panting like a dog to breathe out all that carbon dioxide, which we call carbon diacid. So remember, we'll see Kussmaul respirations as deep, rapid breathing as the body tries to get rid of all this acid. And the memory trick here is carbon diacid. Now next, our A is for abdominal pain, which is a huge NCLEX tip. HHNS does not have abdominal pain, only DKA, typically on the NCLEX. And our last A is for acidosis, metabolic acidosis, guys. Huge NCLEX key number here. Write this down. pH 7.35 or less. Huge number on the NCLEX. It will always show up on SATA questions. Now switching over to type 2, the slower and more serious one since it's harder to fix. So HHNS, guys, remember the triple H's here. We have higher sugar loss with higher fluid loss, so sugar over 600 plus and extreme dehydration. And our third H is for head change. Now the NCLEX term is neurological manifestations. Guys, write that down. We'll often see confusion with classic signs of HHNS. Guys, we don't get head change or neurological manifestations with DKA. Our next N is for no abdominal pain, guys. DKA, we have that abdominal pain, as well as no ketone. So this means no acid, no Kussmaul respirations, basically meaning no fruity breath and no deep, rapid breathing. Now that's probably the biggest difference than DKA. And lastly, S is for our slower onset with stable potassium, 3.5 to 5.0. So when you get an NCLEX question stating high sugars with neurological changes or neurostatus changes, guys, with no acid, definitely HHNS. And if you get a question about a diabetic kid with abdominal pain and that pH less than 7.35, guys, it's most definitely DKA. So guys, what are we gonna do about it? So for DKA treatments, simply remember the acronym DKA. D for dehydration. Guys, we treat the dry first. Keyword is 0.9% normal saline. Now, I got a lot of questions on this from our NCLEX review, so please write this down. Your first priority action for both DKA and HHS is fluids. And the correct answer is always normal saline. Now, K is to kill the sugar slowly, guys, to prevent that low sugar. So we do keyword here, hourly blood sugar checks. Write that down. We want a slow sugar drop. Sugar is really way high, kind of like a plane. So guys, we want to land that plane slowly, not too fast, since we don't want to crash our patients here. The main goal here is to prevent that low blood sugar, that hypoglycemia, that 70 or less. So a slow sugar landing is the goal. So basically, as sugar lowers, then the insulin lowers. We just titrate or adjust the insulin drip and lower them together. Typically, any sugar over 250, we give IV insulin. Now, key term here, regular insulin only. So remember, regular insulin is ready to go IV. And we start with the bolus first, basically meaning rapid infusion. Now, caution, tests will try and trick you guys. Only regular insulin is put right in the vein. Not NPH, not Aspart, not Lispro. No one else here gets the VIP pass. Remember, only regular insulin is right in the vein or ready to go IV. Now, when sugars drop below 200, or when, keyword, write this down, ketones resolve. This means the body is now burning glucose for fuel and not fat anymore. So we switch the patient from IV insulin to sub-Q and then add some dextrose sugar to the IV bag, typically D5W. Now you're probably asking, why do we add sugar if the sugar is already high? Well guys, it's kind of like landing that plane. Sugar is our landing gear. We want a smooth and slow landing, preventing that low sugar crash of hypoglycemia. Now a common test question is always a question about a child in DKA who's too nauseous to eat or maybe vomiting. And the question always says, do you still give him insulin if he doesn't have food? So think about it here, guys. Well, yeah, you still give the kid insulin, guys. His sugar's really, really high. Big NCLEX tip, still give insulin on those sick days. Lastly, we add the potassium. Key word here, write this down. During IV insulin, not after. During, big NCLEX tip. And yes, even when potassium is normal between 3.5 and 5.0. Now you're probably asking yourself why. Well guys, remember, insulin puts sugar and potassium into the cell. So naturally, both sugar and potassium drop together. So to prevent a potassium crash, we add potassium, sort of like how we add sugar. Now a little side note about potassium. Think potassium pumps the heart. So the 4 rules of potassium revolve around protecting the heart with potassium. Number 1, our first action is heart monitor placement. And secondly, guys, we never push potassium. This means sudden death. The heart will cramp up and not pump anymore. Third, we only do 10 to 20 mLs max per hour. Not 30 minutes, not even 45 minutes, guys, per hour, a full 60 minutes or more, usually around 4 hours. And lastly, we always put potassium on an IV pump. Never a solo drip, guys. It's too risky. And as always, slow the infusion pump if the arm starts burning, which is pretty common. Now to help you remember the ECG rhythms with high versus low potassium, our memory trick is very simple here. So just think high potassium, we have high pumps. So we get peak T waves and ST elevations for potassium over 5.0. And the exact opposite for low potassium below 3.5, just think low pumps. So we get flat T waves and ST depression, and even this weird little U wave. What the heck's a U wave? Shut up, you. Now for HHS treatments, guys, remember the acronym HS. We always treat the hydration first. Both DKA and HHS, hydration first. 0.9% normal saline. Huge NCLEX tip, guys. Now, we can always do hypotonic fluids, but that's not as common on the NCLEX. And then S for stabilize the sugar with insulin. Again, caution, guys, only regular insulin is ready to go IV. Big NCLEX tip right there again. And just like DKA, we correct the sugars slowly with key term hourly blood sugar checks and insulin going from IV bolus to subcutaneous injections. We land that sugar slow. Now, as far as potassium for HHS, out of 10,000 questions we took while making the script, the potassium only came with DKA. So guys, remember, adding potassium for DKA. But a lot of questions came up about reassessing the hydration status. So write this down, guys. So we reassess both blood sugar and rehydration status. So for hydration, we'll see stable blood pressure, cap refill 3 seconds or less. And guys, skin, write this down, should not be pale or cold. It should be warm and have some color. Urine output should be 30 mLs per hour or more with normal specific gravity. Too high and the body is dry. So the little memory trick here is hemoconcentration is an indication of dehydration, basically meaning high and dry lab values, very heavy urine. And hemodilution is overhydration, low liquidy labs with low liquidy urine. Lastly, don't let the NCLEX trick you. Rehydration status does not include apical pulse, lung sounds, or even pupil assessment. All right, guys, that wraps it up. DKA versus HHS. Thanks so much for watching. For our full video and new quiz bank, click right up here to access your free trial.
So this is a reminder. I hope it was interesting, and this is a reminder for our Twitter account, IndoDMOS. If you are interested to have more update in the diabetes and endocrinology feed, please follow our Twitter account, IndoDMOS. So let's go for the next topic. The next topic here is about hypercalcemia. We know that the hypercalcemia is one of the emergencies that may be seen in the emergency room related to the medical emergency. And before we describe this entity, I like you please to read this scenario quickly and to answer the question. The scenario here is about 81-year-old male presented to emergency room for altered mental status, found to have at home to be confused, lethargic, past medical history significant for metastatic prostatic carcinoma, examination significant for blood pressure of 110/50, pulse 110, lethargic and minimally responsive to sternal rub. He has bitemporal wasting, mucous membrane dry. Patient has intact gag reflex, withdraw to pain in all four extremities, lab significant for creatinine of 4, calcium is 14, albumin 2.3. So the question, all of the following are appropriate and initial step except A, normal saline, B, pamindornate, C, calcitonin, D, dexamethasone. I need your input, please. So some of you thinks that the exception here is A, what else? So what should we do? So what should we give? Some of you thinks B, some of you thinks that maybe D, A. Oh, it is confusing. So that's why it is very important to discuss such a scenario. Okay, let's discuss the correct answer here. Actually, the correct answer, the exception is the dexamethasone or the steroid. Hypercalcemia is a common oncological complication of metastatic cancer. In this scenario, it is expected to have carcinoma in this elderly man. Regardless the underlying cause, the treatment usually is similar. Symptoms including confusion, lethargy, change in mental status, fatigability, polyuria, constipation, nausea, and vomiting. In severe cases with the calcium more than 3.5 millimole or more than 14, and in symptomatic patient with hypercalcemia, Usually, patients are dehydrated, so it is crucial to start with saline hydration infusion. Severe hypercalcemia, particularly if it is develops acutely, may lead to coma. What about the fluid? The fluid usually normal saline, as we mentioned, 200 to 300 ml per hour, and it is usually adjusted to keep the urine output between 100 to 150. These patients are often dehydrated, as hypercalcemia may cause nephrogenic diabetes insipidus. Therefore, primary management entails re-establishment of eovolemia. But it is very important to know if the patient has underlying cardiac or renal impairment. Please don't give too much IV fluid, because it may lead to overload due to quick hydration, and patient overload will lead to heart failure, will be edematous, and maybe will you push the patient into pulmonary edema. Bisphosphonate, like for example, zoledronic acid, it stabilizes osteoclast resorption of calcium from the bone. Its effects may take 1 to 2 days to manifest. Care must be taken in cases of renal insufficiency, as rapid administration of pamidronate or Zometa, which is zoledronic acid, may also can be used in these cases. But we know that calcitonin is usually given subcutaneously in the first 2 days. Why? Because there is what is called tachyphylaxis, and tachyphylaxis, it means the receptors of calcitonin after 2 days will be not responding, and calcitonin is the proper answer or the proper way to give it subcutaneously every 2 times per day for 2 days. What about steroid coverage? Steroid sometimes is used if there is some underlying mechanism of hypercalcemia. So steroid may be useful in patients with lymphoid malignancies, sarcoidosis, other granulomatous diseases as a mechanism of hypercalcemia. In those conditions, often related to excess hydroxylation of vitamin D. So if there is underlying cause of this excess hydroxylation of vitamin D, you can use steroid. So in this particular scenario, which was mentioned before, steroid, not due to lymphoma, for example, or due to sarcoidosis, so maybe it is not the proper management to start with steroid. Usually, there is increased conversion of 25-hydroxyvitamin D to potent or active form, which is 125-hydroxyvitamin D, which enhance intestinal calcium absorption, leading to hypercalcemia. What about Zometa or zoledronate or zoledronic acid? As we mentioned, it is given infusion 15 to 30 minutes in 100 ml, 0.9% saline. Usually the dose is 4 milligram. Flu-like symptoms, 30% of patients hypocalcemia are the expected side effect. As we mentioned, the calcitonin inhibit bone resorption through interference with the osteoclast. It promotes urinary calcium excretion, and usually due to tachyphylaxis should not exceed 48 hours. If the patient has moderate hypercalcemia, or we can say mildly symptomatic hypercalcemia, calcium less than 12, and usually asymptomatic, avoid factors that can aggravate hypercalcemia is your approach. For example, using thiazide diuretic, lithium carbonate, volume depletion, prolonged bed rest, vitamin D supplementation, and high calcium diet. Asymptomatic or mildly symptomatic individuals with chronic moderate hypercalcemia, calcium between 12 to 14 milligram per deciliter may not require immediate therapy. An acute rise to these levels may cause GIT side effect and change in sensorium, which require treatment as described for severe hypercalcemia. I have a question here for the audience. The most common cause of high serum calcium in a patient with a known cancer is A. Ectopic production of parathyroid hormone. B. Direct destruction of bone by tumor cells. C. Local production of tumor necrosis factor and interleukin-6 by bone metastasis. D. High level of 125 hydroxyvitamin D production. E. Production of parathyroid-like peptide substance. I need your input, please. So we have many mechanisms in which we are seeing hypercalcemia. I'm talking here about hypercalcemia, which is related to the most common cause of hypercalcemia, usually in a patient with known carcinoma. So some of the answers, as you see here, going with A, some going with E. Actually, the correct answer is E. Although it was thought that the commonest cause is direct invasion to the bone due to resorption by the tumor, it is now recognized that 80% of such instances occur because of the production of a protein called parathyroid-like peptide. So there is a production of some of the peptides called PTH-related peptide. It has the same action almost of PTH or parathyroid hormone. Resorption of the bone and hypercalcemia is ultimately the answer or ultimately the result. Parathyroid hormone-related peptide functionally identical to native parathyroid hormone in that it causes renal calcium conservation, osteoclast activation, and bone resorption, renal phosphate wasting. Very important issue to know that the commonest cause of carcinoma with this category is squamous cell carcinoma, for example, of the lung. So squamous cell carcinoma of the lung is the most common tumor associated with this production of parathyroid-related peptide. 20% of the cases of hypercalcemia malignancy are due to local production of substance such as transforming growth factor and interleukin 1 or 6, which cause bone resorption at the local level and release calcium from bone stores. How to differentiate hypercalcemia? Maybe this is upon our topic today, because our topic to cover the hypercalcemia in acute setting, but you have to keep it as a general idea. Hypercalcemia, it is classified into two PTH-related or parathyroid-related, and in the other side, non-PTH-related. If elevated or mid to high normal PTH, maybe you have two differential diagnoses. PTH is high after hypercalcemia. You go for 24-hour urine collection. If it is more than 200 milligram per 24 hour, usually primary hyperparathyroidism it is your diagnosis or provisional diagnosis. Measure BMD, consider guidelines for surgery, is your approach. And if the patient has low calcium, less than 100 milligram per 24 hour, in this situation, familial hypercalcemia is your provisional diagnosis. But if the patient has a PTH is low, it is called non-PTH related hypercalcemia, and we have many differential diagnoses. For example, if related peptide is high, you have to scan for malignancy. This is your differential diagnosis number one. And if the patient has high vitamin D, it is due to vitamin D intoxication. If the patient has lymphoma sarcoidosis, it's expected to have high 125 hydroxyvitamin D. So this is the differential usually in which you have to establish the cause of hypercalcemia after establishment of acute setting. Approximately 20% of individuals with hyperthyroidism develop hypercalcemia related to increased bone turnover. Vitamin D intoxication is a rare cause of hypercalcemia. An individual must ingest 40 to 100 times the recommended daily amount in order to develop hypercalcemia, because vitamin D acts to increase both calcium and phosphate absorption from the intestine, serum level of both minerals would be elevated, which is not seen in this case. Multiple myeloma is another malignancy frequently associated with hypercalcemia due to production of cytokines and humoral mediated by the tumor. Primary hyperparathyroidism and malignancy account for over 90% of the cases of hypercalcemia. In asymptomatic patient, primary hyperparathyroidism is the most common cause. In patient admitted to the hospital, hypercalcemia due to malignancy is the most common cause. So this is a common question. If the patient with malignancy discovered, a patient discovered hypercalcemia in the ward, it means most commonly due to hypercalcemia of malignancy. If in outpatient department, due to hyperparathyroidism as the most common cause. Calcium is regulated into bone, the GIT tract, and the kidney. Other causes of increased bone turnover include Paget disease, immobilization, and hyperthyroidism. Causes of increased GIT absorption include vitamin D intoxication, milk alkali syndrome, hypercalcemia, from thiazide diuretic, and familial hypercalcemic hypocalciuria, as we mentioned before. Few lines about FHH or familial hypercalcemia. It is an inherited autosomal dominant trait result from defect in serum calcium sensing by the parathyroid gland. Usually we have hypercalcemia in the blood, but the urine hypercalciuria is low because with resorption more than 99%. The hypercalcemia is often detected in the first decade of life. I have another question here. Hypercalcemia manifested in ECG by all of the following except A, short QT interval, B, AV block, C, bradycardia, D, ST depression. So let us see your answers. Short QT, ST depression. So there are three correct answers and one wrong answer. We need to go for the wrong answer. Actually, the correct answer here is D. This is the exception. All others, like short QT interval, IV block, bradycardia are seen or observed with hypercalcemia, but ST depression is not. Hypercalcemia causes characteristic changes on the ECG, including bradycardia, AV block, and short QT interval. Intravenous phosphate is not indicated as it chelates calcium and may deposit in tissue and cause extensive organ damage if the calcium phosphate producing product is above 65. The mechanism of the hypercalcemia of sarcoidosis is related to excess vitamin D. Therefore, a calcitriol would be contraindicated. Quick fact about hyperparathyroidism, which is one of the commonest causes of hypercalcemia. Surgical removal of autonomous adenoma is generally curative, but not all patients need to be treated surgically. It is recommended that individuals less than 50 undergo primary surgical resection. So less than 50, one of the indications to go for surgical resection. Patient with more than 50, a cautious approach with frequent laboratory monitoring is observed. Surgery can then be undertaken if the patient develops symptomatic or worsening hypercalcemia or complications such as osteopenia. Breast cancer is a frequent cause of hypercalcemia because of metastatic disease of the bone. I think this is already covered, how to go for hypercalcemia management, IV fluid, 200 to 300 ml per hour, zoledronic acid or bisphosphonate can be given, calcitonin, and according to according to the underlying cause, steroid can be used sometimes, and the definitive treatment at the end may be one of the options available to go for surgery. By this, I am done. And I see some of the questions in the chat box before we are going to the break. Here is why DKA patients sometimes suffer from abdominal pain. I think hyperglycemia in general, because there is hyperglycemia, and we know sometimes hyperglycemia presented with changes in the body, including, for example, this abdominal pain. Maybe the most common issue is the acidosis there. So metabolic acidosis is the underlying mechanism here, and metabolic acidosis may lead to this abdominal pain, which is seen in diabetic ketoacidosis. This is the question what we are seeing here. And so we tried here to cover hypercalcemia, and we try to cover hyperglycemia, which include two subcategories, diabetic ketoacidosis and hyperosmolar non-ketotic status. So still we have many issues to be covered, or many topics to be covered before going further. I think due to time difference in our country, maybe it's better to go for break, either for coffee break or prayer, and then we can resume again in about 35 minutes. So please, we'll be back at 5:15. 5:15 we'll be back after break. So see you again. Bismillah ar-Rahman ar-Rahim. Welcome again to the second session of our topic today. As we mentioned early, we have 3 days of medical emergencies, and we have to cover some important topics with terror emergencies related to neurological or CNS system, cardiac system, endocrinology, and we started in endocrinology in the first session, and now it's the time to go for the to continue this adrenal crisis topic. And we know that the adrenal crisis topic is one of emergencies that you may see them or to see these cases in the in the emergency room. So let us discuss some aspects related to adrenal insufficiency or adrenal crisis. You receive a call from your emergency department because you are a physician in the internal medicine, for example. A 52-year-old female presented with nausea and vomiting and initial laboratory investigations showing hyponatremia. She has a medical history of hypertension controlled on amlodipine, and she represented a 1-month history of fatigue, weakness, and dizziness. Over the past week, she had developed nausea and decreased appetite. The vomiting started yesterday, and she presented to emergency department because she was unable to tolerate the fluid. She has not taken her medication for at least a week. She looks ill. Her blood pressure is 100/70. Pulse rate is 102. The physician cannot detect the hyperpigmentation because of her color ethnicity, and she is vomiting repeatedly. And abdominal examination, she has diffuse tenderness but no gardening or rebound. Laboratory results shows sodium 124, potassium 5.2, bicarbonate 20, creatinine 1.2, serum urea nitrogen 24, calcium 10.2, hemoglobin 12.5. The emergency department physician is concerned about her adrenal function. He has already initiated intravenous fluid and wants to give her hydrocortisone, but he asks for you the advice about the before initiation of the therapy. So the question here, which of the following is the best diagnostic test to order now? You will order A, ACTH and cortisol measurement. B, cortisol measurement 30 minutes after administration of 250 mcg of cosyntropine. C, salivary cortisol. D, aldosterone and renin measurement. E, cortisol measurement and assessment of 21-hydroxylase antibody. I need your input, please, down in the chat box. I'm waiting your answers. B, E, A. What else? Any other suggestion? So let us see the answer here. The answer actually here is A. So it is very important because you are now in the emergency room and it is not the time to diagnose, but at least you have to extract or take some blood sample. So which is a very important blood sample here to be taken. The very important one was the most important one is ACTH with cortisol measurement. And we know that taking the cortisol measurement and ACTH is the first one. can be taken immediately in ER, then you can inject your hydrocortisone intravenously. What about the other synactin test? It is not appropriate now to go for 30 minutes and to go for diagnosis, and you will delay the management suspected in this patient of adrenal insufficiency, and you will delay the steroid. If you delay steroid, patient may deteriorate and go for hypotension and maybe collapse. Aldosterone adrenal measurement usually and salivary cortisol, it's not a lab investigation for cases of adrenal insufficiency. 21 hydroxylase antibody in the acute setting, or even usually not used in the clinical situations. What about the disorder or the adrenal insufficiency disorder? It is a disease characterized by failure of adrenocorticoid cortical function, resulting mainly in impaired secretion of glucocorticoid only, or both glucocorticoid and mineralocorticoid. The adrenal crisis potentially is a life-threatening medical emergency of adrenal insufficiency. The first who discovered this disease was Thomas Allison in 1855. This is the scientist, the first described as an infection of the adrenal gland, mostly due to tuberculosis. Now, instead of infection, we have many causes, and we know the most important one is the autoimmune destruction. This is the adrenal gland. We know we have Zona reticularis, and we have Zona reticularis, which secrete androgen, and Zona fasciculata, which secrete glucocorticoid, and Zona glomerulosa, which secrete mineralocorticoid. This is what we call HPA axis, the hypothalamus pituitary axis. From the hypothalamus, there is CRH secretion. This is corticotroph releasing hormone, which stimulate pituitary to secrete ACTH, and this ACTH will work on the adrenal gland, and we know the adrenal gland, or what was called suprarenal gland, which is seen or located above the kidneys in both sides, right and left. It affects the adrenal cortex to produce the glucocorticoid. And one very important issue, mineralocorticoid is not under the effect of ACTH. So the ACTH is affecting only the glucocorticoid, or there is a correlation with HPAS, but there is no correlation with mineralocorticoid. Increased renal, this is the physiology as we mentioned before. This is the physiology of mineralocorticoid. Mineralocorticoid is usually associated, or there is association with the kidney, or there is what we call renin-angiotensin system. And this is the relation between angiotensin system and aldosterone secretion, which is released from adrenal gland. So the mineralocorticoid, which is released from the adrenal gland, may decrease sodium excretion, leading to increased extracellular fluid volume, leading to increased renal arterial mean pressure, decreased discharge of renal nerve. So there is renin secretion, which work on angiotensin to become angiotensinogen, which is converted to angiotensin 1, and with enzyme called angiotensin converting enzyme will be transformed to angiotensin 2, which affect the adrenal gland. So this is how we are managing mineralocorticoid. What is the mineralocorticoid effect? It play a role in sodium and potassium level in the body of the human being. So if there is hyponatremia and hyperkalemia, it means mineralocorticoid is affected. And by this way, there is correlation between kidney and mineralocorticoid, as you can see here. what are the causes of adrenal insufficiency in general? As we mentioned before, the primary Addison disease, it is caused by autoimmune adrenalitis, isolated adrenal insufficiency, and it can be part of polyglandular autoimmune syndrome, either type 1 or type 2. And the second issue is infectious adrenalitis, either due to tuberculosis, for example, disseminated fungal infection, histoplasmosis, coccidomycosis, HIV, syphilis, African trypanosomas, or are the infections that can be seen in the clinical practice, and also metastatic carcinoma also may affect the adrenal gland, leading to this adrenal insufficiency. Also, some of the drugs, for example, patient using phenytoin, rifampicin, fluconazole, ketoconazole, may lead to this primary adrenal insufficiency. If there is hemorrhage or infarction or some medication like warfarin, for example, anticoagulant, may lead to hemorrhage, for example. Also, we can observe this side effect or this disease as an underlying cause. Congenital adrenal hyperplasia, also one of the causes. What about the secondary and tertiary what is the difference between primary, secondary, and tertiary adrenal insufficiency? Usually in primary adrenal insufficiency, the disease or underlying disease is the adrenal gland itself, but in primary and in secondary, there is the affected gland is either pituitary or hypothalamus if tertiary. So if there is central adrenal insufficiency, the cause will be from up means either hypothalamus or pituitary gland. ACTH will be low, leading to low cortisol level. But if the patient has primary adrenal insufficiency, the primary disease in the adrenal gland itself leading to low cortisol, and as a physiological response, you will observe high ACTH in the blood stream. So to differentiate between the two, primary and secondary, you have to measure both, adrenal cortisol level and ACTH. I will repeat myself again. Low cortisol level with high ACTH means primary adrenal insufficiency. Low cortisol with low ACTH leading to secondary adrenal insufficiency. The abrupt withdrawal, what are the causes? Maybe patient using steroid, whatever the underlying cause. For example, patient is known to have lupus or any rheumatological connective tissue disease using steroid for a long time, and there is an abrupt withdrawal of this medication leading to adrenal insufficiency acutely. Some pituitary tumors, if the patient has pituitary tumor which affect the adrenal tissues, the ACTH tissues, it means low ACTH will be produced, low ACTH leading to low cortisol due to the compression from the pituitary gland tumor. Supracellular tumors also would affect the pituitary gland, leading to the same scenario. Metastasis to the pituitary, pituitary surgery or irradiation, all of these are well known to cause secondary or tertiary adrenal insufficiency. Lymphocytic hypophysitis, also infection like TB and histoplasmosis, infiltration, hemochromatosis, sarcoidosis, and histiocytosis X, genetic causes, and severe head trauma, as we observed in some cases of RTA or road traffic accident. Precipitating factor in patient already known to have chronic adrenal insufficiency, may be presented with acute crisis, as we know. So what are the possible causes? Sudden withdrawal of the steroid, as we mentioned, abrupt withdrawal of the steroid, or sudden withdrawal, whatever, maybe poor compliance to the patient. Patient is missed the dose, leading to this acute crisis. If the patient has infection or severe infection, like myocardial infarction, cerebrovascular accident, pneumonias, etc., with sepsis, so patient will be under stress, and this is a stressful condition. Patient needs more steroid coverage. So relatively, he is deficient on steroid, and he needs more steroid coverage. In this usually situations, or in these situations, need to have more steroid coverage, either intravenously, or sometimes if the situation is less, we can say, critical, maybe tripling the dose is important. What about the surgery and delivery? The same issue. Severe trauma, the same issue. Using some medication like phenytoin, ketoconazole, also may lead to the same issue. Bilateral adrenal hemorrhage, as I just mentioned, using anticoagulant therapy like warfarin, leading to hemorrhage inside the adrenal gland. Bilateral adrenal infarction, DIC, disseminated intravascular coagulation, antiphospholipid syndrome, also may lead to this situation. Severe head trauma, sudden pituitary hemorrhage, and sudden pituitary infarction. Whatever the underlying cause, for example, hypertension, or we can say DVT, or thromboembolic, we can say phenomena leading to the same situation. What about the expected clinical features that is seen here? We can see that patient may be presented because of adrenal insufficiency with dehydration, hypotension, shock out of proportion to severity of current illness, nausea and vomiting with a history of weight loss and anorexia, abdominal pain, so-called acute abdomen, unexplained hypoglycemia, and unexplained fever. So maybe this is what we will see in the emergency room: abdominal pain, unexplained hypoglycemia. Why hypoglycemia? We know the steroid also play a role as anti-insulin medication, anti-insulin hormone. Insulin, we know, it's decreasing the glucose, and the steroid increasing the glucose. So if we have no steroid, or cortisol is low, we are expecting to have hypoglycemia. This is to make it simple how to understand why we are observing. This is one of the important rule of cortisol physiology in the human being. Dehydration, hypotension due to, as we mentioned, fluid loss is sometimes observed. It is pathognomonic to find hyperpigmentation in primary. I am repeating myself. It is pathognomonic to find hyperpigmentation in primary adrenal insufficiency, not in secondary. Because high ACTH may play a role in melanocyte, and melanocyte will lead to this hyperpigmentation. So one of the clinical findings that you have to look for is the hyperpigmentation. So hyperpigmentation observed, for example, in the buccal mucosa, or sometimes in the we can say extensors can be seen in primary adrenal insufficiency. You see here in the creases, for example, you can see the hyperpigmentation also. Laboratory finding: what are the laboratory findings that can be seen in patients with adrenal insufficiency? Maybe you can observe eosinophilia, renal function test, dehydration, acute renal failure or azotemia, blood glucose will be very low, sometimes hyponatremia as well, hyperkalemia due to renin angiotensin system defect. Very important point, hyponatremia can be seen in both, in primary and in secondary, but hyperkalemia, I'm repeating myself again, hyperkalemia is seen only in primary adrenal insufficiency, but hyponatremia or electrolytes imbalance usually is associated with a primary, but the main issue is hyperkalemia. This is only seen in primary because of the renin-angiotensin system disturbance. Hyponatremia, the mechanism in the secondary adrenal cases is different, and it's not that to know the underlying cause here, because it needs a long discussion. Mild hypercalcemia also can be seen. Random cortisol may help you, because if you extract the cortisol in a stressful condition, it is expected as a normal physiological response to have a sky-high cortisol. But if it is, we can say, relatively normal, it means patient has adrenal insufficiency, and by this way you may diagnose adrenal insufficiency in situations like a patient admitted for in ICU, for example. SDH, as we mentioned before, to differentiate between primary and secondary adrenal insufficiency. Sorry, and aldosterone, maybe it is not important in the clinical practice, but as we mentioned, there is a disturbance in the aldosterone in the primary adrenal insufficiency. Basal ACTH, renin, and aldosterone used to differentiate between primary and secondary. It is not usually measured in the clinical practice, but you have to know what is there. Usually ACTH is high in primary adrenal insufficiency, low aldosterone and high renin, and in secondary ACTH is low, or we can say relatively normal, renin and aldosterone not affected, as we mentioned. Differential diagnosis before you start management, you have to look for other causes of shock, like for example, maybe patient has septic shock due to the infection, cardiogenic shock if patient, for example, has heart failure, and other causes as well. Let's now go for the management of adrenal crisis. A very important issue. Please, 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 if you suspect a patient with adrenal crisis in an emergency room, don't delay the management. You have to start the treatment immediately if there is query or suspected case. Why? If you delay the treatment, patient may go, maybe you will go for deterioration. Hypotension, collapse can be observed, and shock and etc. Hyperkalemia, leading to, for example, cardiac arrest. Before going for management details, I will read this scenario. A 46 female presented to ER with 1 day history of fever, headache, and lethargy. She reports having developed myalgia, lethargy, mild headache, cough with previous day, and having become febrile to 39.1. She decided to seek medical care after she started experiencing nausea, vomiting, and perisyncopal symptoms while urinating. She has a history of Hashimoto-thyroiditis, primary adrenal insufficiency. She is using levothyroxine 125 microgram daily, hydrocortisone 15 gram in the morning and 10 milligram in the afternoon, and hydrocortisone 0.05 milligram once daily. Her blood pressure is 88 over 49. Her heart rate is 104. Her temperature 38.5. She has an oxygen saturation of 99% while breathing. On a physical examination, the patient appears uncomfortable. There is a slight injection of her conjunctiva and erythematous oropharynx with some cervical lymphadenopathy. The patient thyroid gland is not palpable. Cardiac examination is not notable for regular tachycardia and otherwise unremarkable finding. In addition to intravenous normal saline, which of the following agent is best to initiate in this patient with hypotension? Please, I need your input. You will give hydrocortisone 100 milligram IV, B, hydrocortisone 45 milligram orally, hydrocortisone 0.1 milligram orally, prednisolone 30 milligram orally, dexamethasone 16 milligram IV. I need your input, please. Sorry. So let us see your answers. We are seeing that A is the majority of you. Yes, you are correct. A treatment of patient who presented with possible adrenal crisis should not be delayed while diagnostic tests are performed. So just extract the blood in few seconds and inject hydrocortisone is your approach. Admission to ICU, yes, in patient with adrenal crisis, hypotension, and instability, prefer to go for ICU. Maintain airway and breathing, ABC stabilization, connect to cardiac monitor, as well establish intravenous access with 2 large bore cannula. And as we mentioned, you can take the blood sample for cortisol, ACTH, renin, and aldosterone quickly. Collect venous blood sample for urea, electrolyte, glucose, full blood count, bicarbonate infection screening, if also appropriate, to know the underlying cause, maybe as we mentioned before. This is very important. Fluid replacement. This is usually suspected to have hypovolemia in these cases. So rapid infusion of 1 liter isotonic saline with within the first hour is very important, followed by continuous intravenous fluid, usually infuse 1 to 3 liter normal saline within 12 hours. Adding 5% dextrose in normal saline if there is evidence of hypoglycemia. So maybe also hypoglycemia is used to be treated with dextrose. If you are observing hypoglycemia, maybe you can give dextrose normal saline instead of giving normal saline, plain normal saline. Glucocorticoid replacement, as we mentioned, you have to give stressful dose, bolus in ER with 100 milligram of hydrocortisone, followed by 50 milligram intravenous every 6 hours. Dexamethasone can be used as alternative. Mineralocorticoid replacement, is it important to be given? No, because why? Because as you see here, there is coverage with high hydrocortisone with mineralocorticoid work. It is not important to give fludrocortisone in the emergency situations. It is very important if a patient patient is stabilized and went down to physiological hydrocortisone. At this time, you can add fludrocortisone, especially if fluid is off. What about stabilization of the patient? Search for and treat possible infectious precipitating cause of adrenal crisis. Continue IV isotonic saline in the next 24 to 48 hours after you are after giving high fluid correction. Taper parenteral glucocorticoid over 1 to 3 days. If the patient is stabilized, then you can go down with the steroid till you reach the physiological dose or maintenance dose of glucocorticoid. In primary adrenal insufficiency, you have to give oral both mineralocorticoid and glucocorticoid coverage, and mineralocorticoid coverage with fludrocortisone is your approach. Perform ACTH synactin test if patient is not diagnosed 100% after stabilization. If not available, check morning cortisol and ACTH. And I think as emergency point of view in this course, it is not the way to discuss all how to, diagnose adrenal insufficiency. Maybe we have another course later on, inshallah, to go further with the diagnostic tools in adrenal insufficiency. I'll give you a quick overview. You will give ACTH 250 mcg, and you will measure 0, 30, and 60-minute cortisol level. If it is more than 500 after ACTH stimulation, it means rule out adrenal insufficiency. If it is less, it means patient has adrenal insufficiency, and we did not reach the maximum response, which is 500. So this is simply how to go for synactin test, and there are a lot of other explanation, other way or maneuvers to diagnose adrenal insufficiency, but maybe baseline serum cortisol is your first approach. Give ACTH 250 mcg intravenous or intramuscular, measure 30 minutes and 60-minute cortisol. Usually, physiologically, there is a good response. If it is more than 500, it means a good response, rule out adrenal insufficiency. If there is no good response, less than 500, what does it mean? Patient has adrenal insufficiency. The treatment, usually the physiological or the maintenance dose of glucocorticoid is 30 milligram per day. Usually we are giving 20 in the morning and 10 in the evening, or prednisone can be given 5 or 7.5 milligram per day. Mineralocorticoid replacement in primary adrenal insufficiency usually can be given like 0.05 up can be given, or 0.1 or maybe 0.2 milligram orally can be given daily. A quick overview for how to deal with adrenal insufficiency cases, a very important issue. Please, any patient with adrenal insufficiency should have a report in with the patient. Why? Because at any time, patient may go for collapse or patient deteriorate. So if he or she visits the emergency room with this card or with this report, the physician there or healthcare provider there will understand the situation and will go immediately for steroid to cover the stressful condition, because most probably patient with adrenal insufficiency need steroid coverage as the number one treatment in the critical situations. So this is how to deal with any patient with adrenal insufficiency. But suppose patient is going for operation, what should we do? Again, it is considered it is considered again a stressful condition, and if the patient has minor to moderate procedure, maybe hydrocortisone 25 to 75 milligram should be given intravenously also to overcome this stressful condition. Major procedure, hydrocortisone 100 milligram intravenous injection followed by 50 milligram every 6 hours. Again, is the approach to cover major procedure, for example, post-cabbage, coronary bypass, or big operation for the laparotomy or whatever. This is the coverage with steroid, which is usually needed or recommended. Again, one of the important issue, if you discharge your patient with adrenal insufficiency, patient who develop acute febrile illness, should double or triple the dose of steroid, as I mentioned before. For example, patient with non-adrenal insufficiency has upper respiratory tract infection, and usually, upper respiratory tract infection within 3 to 5 or maximum 1 week, we have a good recovery. So in this situation, you will ask your patient to go for a rule of 3 by 3. What does it mean? Triple your dose by for 3 days. It means if patient is using 30, he will go for 90 for 3 days, and then he will go back, or she will go back to the maintenance dose. So this is how to usually we advise our patient in the outpatient department how they are dealing with the febrile illness or minor upper respiratory tract infection. Patient and their relative should be learned about adrenal insufficiency. Dexamethasone injection also can be kept with the patient. There are some injections to be kept at home, can be given in emergency situation by the relative of the patient. As I mentioned before, card or report should be given to any patient with adrenal insufficiency, or sometimes bracelet like this can be used to cover to understand the situation by the healthcare provider in emergency situations. I hope it was interesting. I'm done with this topic. And this is how to deal with adrenal insufficiency cases. So let's go for Q&A box quickly. Okay, we have here a question about which level of cortisol that detect adrenal insufficiency. As I mentioned before, because we are talking about emergency topic today, that's why I did not go for details. But because we have this question, I will answer it quickly. If the patient, for example, has a very low cortisol, which is defined less than, we can say 90, it means suggestive or more suggestive of adrenal insufficiency. Maybe in some cases, if you are sure, you can go for adrenal, especially if the patient has symptoms and signs, you can depend on it and you diagnose this patient and you prescribe the medication. But if it is more than 500, I mean cortisol AM, it means patient has ruled out, or we rule out the adrenal insufficiency. What is the role of synactin test? If the patient has a gray zone, what do we mean by gray zone? The gray zone if the cortisol level between 90 or 85 up to 500. This is considered a gray zone, and synactin test is your approach, or confirmatory test should be used. I hope that I answered your question. I think we'll try to manage the slides inshallah. طيب, let's go further. I think still we have time. Before break, I mean. I will share now one of the important topic to be discussed in the clinical practice. And we know that the emergency situation usually differs from either to see, for example, central nervous system, or to see gastro, or to see cardiac, or to see, for example, rheumatology, emergency situations. So in internal medicine, we have observed a many, we can say, a many side of emergency situation. So I think now to go further, we'll try to cover central nervous system. Sorry. And the central nervous system topic here, I will try to share with you is status epilepticus. So you may see the status epilepticus in the emergency room. So what are the clinical features, pathophysiology, and treatment of status epilepticus? Status epilepticus, one of the emergency, you see here, patient has seizure. In this diagram, he's connected to the cardiac monitor. There is injection of the medication. This is what we are usually dealing, how we're usually dealing with it, with the status epilepticus. So it is continuing or recurring seizure in which recovery is incomplete. It is a condition characterized by an epileptic seizure that is also frequently repeated or so prolonged as to create a fixed and lasting condition. Any seizure activity lasting more than 30 minutes also is under this category. The classification of status epilepticus, it is a generalized convulsive status epilepticus, either to be tonic-clonic seizure, tonic status epilepticus, clonic status epilepticus, myoclonic status epilepticus. Generalized then conclusive status epilepticus, absence status epilepticus, simple partial focal status epilepticus, somato-motor status epilepticus, sensory status epilepticus, aphasic status epilepticus. So anyone can be observed. The incidence is usually 60,000 cases of generalized tonic-clonic status per year in the United States. 1/3 consists of first seizure of a recurrent problem. 1/3 in patient with the prior diagnosis of epilepsy. 1/3 in patient without a history of epilepsy. Most frequent in children and patient more than 60. Mortality 1 to 2% from the seizure. So there are some mortality cases observed in the status epilepticus. That's why it is very important to deal with these cases in the emergency room. The annual hospital visit for acute seizure, 368,000 patient visit to emergency room. 50,000 breakthrough seizure are treated annually. And status epilepticus, actually 50,000 to 60,000 1 to 8% of hospital admissions. Age distribution, you see here 60 to 70% to 79 is the high score distribution of the status epilepticus as per recommendation, as per statistics, and mortality in status epilepticus by age group, again in the elderly 80 and above. Status epilepticus etiology may be due to, for example, some newly introduced drugs, alcohol abuse or withdrawal, CNS or central nervous system tumor, congenital central nervous system abnormality, CVA, fever, acute systemic or metabolic illness, CNS infection. Anti-epileptic incompliance, all of these also one of the underlying cause of status epilepticus. And this is the percentage usually, maybe in patient with known to have epilepsy, the non-compliance issue is number one differential diagnosis. Morbidity and mortality, CNS damage due to underlying illness or acute insult, CNS damage due to repeated seizure, systemic and metabolic factor related to repeated generalized tonic-clonic convulsion. Status epilepticus has a distinct natural history, more prolonged to the status, the more interactable to treatment it is. More prolonged the status, the poor the prognosis. EEG pattern, we know that one of the diagnostic tool to be used in seizure disorder generally is the EEG pattern, but maybe it's not the time to discuss the details of EEG, because in emergency room, usually we have to focus on how to manage these cases, and maybe diagnostic tool can be used later on. A status epilepticus with the consequences or complication. Number one, prolonged status may lead to damage to cerebral cortex, cerebellum, thalamus. Childhood status may have hippocampal sclerosis. All these can be observed as a consequences or a complication. So let's focus on management. Time to treat of treatment of status epilepticus. Retrospective review of treatment access time of 30 patients with status epilepticus admitted to emergency department in one of the centers. Usually onset of status to arrival 30 minutes. 20 minutes, 35 minutes. We can say the statistics of this study to understand the early you intervene, the better outcome. So you have to put in your mind the early coverage and the early intervention. Survival care for prolonged and non-prolonged seizure. Length of seizure, if you intervene early, there is definitely a better outcome. Major drugs used to treat status epilepticus. So what are the usual medication used in the status epilepticus? The major drugs used to treat status epilepticus, IV doses, including the following. Diazepam, and the usual intravenous dose is 0.1 to 2.25 milligram per kg, and maximum administration milligram per minute rate, 5, and lorazepam, phenytoin, phenobarbital, or phenobarbital is the usual medication can be used with the doses. Treatment of status epilepticus, obtain vital signs. This is number one job. Establish airway, administration of oxygen, observe seizure, to ascertain that patient is really in status draw baseline blood work, CBC, chemistry panel, antiepileptic drugs level. Why? Because sometimes patient maybe has, for example, hypocalcemia, and hypocalcemia may be presented with seizure. So it's not usually, it's not 100% a CNS infection, CNS, I mean, normality or disorder. Maybe sometimes there is an other underlying cause. Quickly assess patient for signs and symptoms of cardiorespiratory compromise, hyperpyrexia, etc. Within 6 to 9 minutes, start IV infusion with saline solution. Give 100 milligram thiamine intravenously. Give 50 ml of 50% glucose solution. If blood sugar is low or unobtainable, don't give glucose if blood sugar is normal or high. Always have CPR equipment and CPR team around. Within 10 to 45 minutes, infuse lorazepam, for example. Begin intravenous loading dose of phenytoin. So what are the antiepileptic medications that should be given after lorazepam or the first initial drug? The antiepileptic drugs, which is usually be given, is phenytoin. Monitor patient blood pressure, pulse, ECG, and respiration, and look for side effect hypotension and arrhythmias. Within 46 to 60 minutes, if seizure persists, intubate and give phenobarbital 20 milligram per kg at 100 milligram per minute. Never use Valium and phenobarbital sequentially in the treatment of status unless the patient is intubated and in ICU. Their hypotensive and respiratory depressant action synergize. Within 1 hour, if seizure persists, the patient should be placed in a drug-induced coma with phenobarbital, benzodiazepine, or other anesthesia agent to prevent life-threatening lactic acidosis, hypoxia, hyperthermia, and permanent seizure-induced neuronal damage. The patient must be in ICU. Outcome should be monitored and treatment guided by EEG, with goal being suppression of the seizure focus or seizure activity. I have a video here to summarize what we have mentioned, so please concentrate.
Okay, in this video, we'll be talking about emergency treatment of status epilepticus. We'll talk about what is status epilepticus and how do you manage status epilepticus in emergency department. First of all, what is status epilepticus? Any seizure that lasts more than 5 minutes is called as status epilepticus. Or the patient is having cluster of seizures, one seizure after another, another seizure after another, with patient not recovering a normal mental status in between, that the patient is having so many seizures one after another and the patient is not developing a normal mental status in between those seizures. That is called as status epilepticus. It occurs in 30% of the patients who are non-compliant with the medication. The non-compliance with the medication, like these patients are already diagnosed with epilepsy and they are non-compliant with the medication, therefore they develop status epilepticus. And status epilepticus increases the risk of permanent brain damage, since there is abnormal electrical activity. That abnormal electrical activity can damage brain cells. Patient can develop hyperpyrexia, since increased muscle contraction can generate heat with it. That heat can result in hyperpyrexia. Increased ATP breakdown will cause hyperpyrexia. Patient will develop acidosis, and since that more energy is being consumed, more carbon dioxide is being generated, and that carbon dioxide will result in acidosis. Patient can develop hypoxia, since that increased metabolic demand due to increased muscular contraction, the oxygen supply will be unable to meet the demands. And patient can also develop respiratory compromise when these abnormal muscle contractions start affecting the respiratory muscles. Management of status epilepticus involves ABC approach. You first check the airways, you secure the airway, and you give the oxygen to patient. And tongue is secured by placing any soft object between the teeth. Remember, never put your hands in anyone who is seizing at the moment, because they can chop your fingers off. So never put your hand into a person's mouth who is seizing at that moment. And to protect their tongue, you should put anything soft object between the teeth so that they do not chew away their tongue. You pass two IV lines, and while you are passing those two IV lines, you obtain blood and you run a certain investigations. You do blood glucose, you do calcium electrolytes and creatinine. Since you are looking for the cause of this patient developing a prolonged seizure, you may look for glucose levels, because hypoglycemia can result in can precipitate into a seizure. Abnormal electrolytes can precipitate a seizure. So two IV lines are placed and blood is obtained for investigations. IV dextrose is given even if you are not suspecting hypoglycemia. Even if you are not suspecting that that patient is having low glucose, you still give IV dextrose, because this increased muscular activity, it can result in hypoglycemia, and also hypoglycemia is a precipitating factor for status epilepticus. So that IV dextrose is not going to do any harm, it's going to give advantage to the patient. Diazepam 5 to 10 mg IV directly into the vein is given at the rate of 1 to 2 milligram per minute. It will control the fit rapidly most of the time. Benzodiazepine will shut the brain down, shut that abnormal activity, and will result in cessation of the seizure. It can be diluted in 10 to 20 ml of normal saline as well. I can also give it directly into the vein. And remember, when you are giving this benzodiazepine can also cause respiratory depression. So you must have facilities of intubation also available with you in the facility when you are giving any benzodiazepine IV. If still the seizure is not controlled after giving benzodiazepines, then what you need to do is that you have to give phenytoin. You add phenytoin, and remember, you should not give phenytoin into that dextrose IV line that you have started, because phenytoin precipitates into the glucose solution. So it should be given through glucose free IV line. And loading dose of phenytoin is 20 mg per kg. Infusion rate should not exceed 50 milligram per minute. Effects of phenytoin will be visible within 20 minutes after administering it. And side effects of phenytoin include hypotension and arrhythmia. Even after giving phenytoin, if the patient is still seizing and the seizures are not controlled, then what you need to do is that you have to consider phenobarbital. Phenobarbital can be used with a loading dose of 20 mg per kg, and it is usually sufficient to stop the fits. In the worst case scenario, if the seizures are still not controlled, even after giving phenytoin, what you can do is that you can increment phenobarbital with further dosage of phenytoin. Dose of phenytoin should be increased by 5 to 10 mg per kg increment. So this is an increment that you are adding. This is additional phenytoin that you are giving over the phenytoin that you gave before to suppress this abnormal electrical activity in the brain. It can be increased by 5 to 10 mg per kg till the seizures are controlled, and infusion rate should not exceed 50 mg per minute. Even if the seizures are still not under control and 30 to 60 minutes have passed, you have done everything, and the patient is still seizing. In that situation, it is called as refractory status epilepticus. If what happens in refractory status epilepticus, that the patient is resistant to all your treatment, what you need to do now is you have to put that patient down into general anesthesia. And if you have decided to put that patient into general anesthesia, you are giving midazolam or propofol to induce general anesthesia, you have to shift that patient to ICU. In ICU, when you are giving general anesthesia, you have to give the patient artificial ventilation. You will need to consider intubation with it. So refractory status epilepticus, that patient will straight away should be shifted to an ICU facility. So in summary, we started our treatment with an ABC approach, and then we gave diazepam to control the seizure. If the seizure is not controlled, we gave phenytoin. And if the seizure is not controlled with phenytoin, we added phenobarbital to treatment regimen. Even if the seizures are not controlled, we increment the phenytoin dose further till the seizures are controlled. And the maximum limit should not exceed 50 milligram per minute. And even if the seizures are still not controlled, you shift the patient to ICU and you put the patient into general anesthesia. Most common cause of these epileptic patients developing status epilepticus is either discontinuation of anticonvulsant drugs, like these patients were started on certain treatment regimen and now they are non-compliant with the medication and they develop such resistant seizures, developing status epilepticus, or any acute febrile illness, any active infection can even precipitate an epileptic seizure resulting in status epilepticus. So you need to consider these factors, and if there is any precipitating factor, treat that. And if the patient is non-compliant with the medication, you should make sure that while patient sending that patient back to home, you make sure that the patient is now compliant with the medication. Complications of status epilepticus include aspiration. Since that patient is having abnormal muscular contractions, abnormal reflexes, those that patient can develop aspiration. And increased muscle contraction can result in rhabdomyolysis, resulting in increased CPK and hyperthermia and damage to the body due to hyperthermia. In summary, we talked about status epilepticus, any seizure lasting greater than 5 minutes. ABC approach, IV lines, IV dextrose. Diazepam, phenytoin should be given in glucose-free IV line. Phenobarbital and then increment of phenytoin. And then refractory status epilepticus needs to be treated with general anesthesia in ICU. If you liked my video, please click on the subscribe button and check out my other video on epilepsy. The link of the video is given in the description below. Thank you very much.
Okay, I hope that it was a good summary to summarize what we discussed about status epilepticus. I think it's the time now to go for prayer time. So we'll be back, inshallah, at now it's already 6:17. We'll be back at 6:50. So please be back at 6:50 sharp. Assalamu alaikum wa rahmatullah. Welcome again to the last session of our first day in our emergency or medical emergency course. And I will try here to share with you the next topic. I hope the sharing is okay. Yes. So in this topic, we'll try to focus on some, again, neurological manifestations or emergencies that is or which can be observed in emergency. One of the important topic is meningitis, and let's give some hints about meningitis and how to deal with them in emergency situation. Meningitis is inflammation of the protective membrane covering the brain and the spinal cord. It is called meninges, as we know. The inflammation may be caused by infection with virus, bacteria, or microorganism. Meningitis can be life-threatening because of the inflammation, proximity to the brain and the spinal cord. Therefore, the condition is classified as a medical emergency. So again, this is the very important note. Meningitis is life-threatening because of the inflammation, proximity to the brain and the spinal cord. Therefore, this condition classified as medical emergency, and that's why we are talking about it today. Meningitis is usually caused by infection from virus or microorganism. Most cases are due to infection with virus, with bacteria, fungi, parasite, being the most common causes. It may also result from various non-infectious causes. Bacterial causes, the types of bacteria that cause bacteria meningitis vary by the age group. In premature babies, for example, E. coli, Listeria monocytogenes is usually observed. Older children are commonly affected by Neisseria meningitis, Streptococcus pneumoniae, and Haemophilus influenzae. In adults, usually Neisseria meningitis and Streptococcus pneumoniae as the organism. Since the pneumococcal vaccine was introduced, rate of pneumococcal meningitis declined in children and adults. Recent trauma to the skull give bacteria in the nasal cavity the potential to enter the meningeal space, which lead to meningitis. Individuals with a cerebral shunt or related device are increased the risk of infection through those devices. In these cases, infection with the staph more common. So if we are talking about shunt patient, please know that the most common cause is staph organism. In a small proportion of people, an infection in a head and neck area such as otitis media or mastocytitis can lead to meningitis. Recipients of cochlear implant for hearing loss increase to have, or the risk increase to have pneumococcal meningitis also. Tuberculous meningitis, meningitis due to infection with Mycobacterium tuberculosis is more common in those from countries where tuberculosis is common, but also encountered in those with immune problems such as AIDS. One of the third generation cephalosporin antibiotic recommended for the initial treatment of bacterial meningitis in young children with those over 50 years of age, as well as those who are immunocompromised. So, for example, third generation cephalosporin like ceftriaxone, for example, addition of ampicillin recommended to cover Listeria monocytogenes. Tuberculous meningitis require prolonged treatment with the antibiotic. Steroid sometimes is used as adjuvant therapy. Also, viral meningitis typically require supportive therapy Only the virus responsible for causing meningitis are not amenable to specific treatment, so supportive or symptomatic treatment is recommended. For example, fever, need an antibiotic, analgesia, IV fluid, etc. Fungal meningitis, such as cryptococcal meningitis, treated with long course of high dose antifungal therapy like amphotericin B. What about viral and parasitic viruses which may cause meningitis, including enterovirus, herpes simplex virus type 2, Varicella zoster 2, Varicella zoster virus, mumps, HIV, parasitic. Parasitic causes often assumes when there is a predominance of eosinophilia in the CSF. So one of the hints, if you observe eosinophilia in the CSF, it means parasitic is the underlying cause. The most common parasite implicated are angio, strogenolus, schistosoma also. Meningitis may occur as the result of several non-infectious causes: spread of cancer to meninges, malignant or neoplastic meningitis, certain drugs, mainly non-steroidal anti-inflammatory drugs, antibiotic, and intravenous immunoglobulin. It may also be caused by several inflammatory conditions such as sarcoidosis, which is called neurosarcoidosis. Connective tissue disorder, such as systemic lupus erythematosus, certain form of vasculitis, inflammatory condition of blood vessels, such as Behçet disease, epidermoid cyst and dermoid cyst may cause meningitis by releasing irritant matter into subarachnoid space. Rarely, a migraine may cause meningitis. The mechanism usually the meninges compromise three membranes that together with cerebrospinal fluid enclose and protect the brain and spinal cord. The biomatter is a very delicate impermeable membrane that firmly adhere to the surface of the brain following all the miner's contour. The arachnoid matter is closely fitting sac on top of the biomatter, and subarachnoid spaces separate the arachnoid and biomatter membrane filled with cerebrospinal fluid. The outermost membrane, the dura mater, is a thick, durable membrane which is attached to both arachnoid membrane and the skull. In bacterial meningitis, bacteria reach the meninges by one of two main routes, either from the bloodstream or direct invasion, either for example, from nasal cavity or the skin, or for example, or there is trauma or whatever. In most cases, meningitis follows invasion of the bloodstream by organisms that live upon mucous surface, such as nasal cavity. So maybe it is a normal flora, and because of the disturbance occur due to, for example, trauma or whatever, this normal cavity, normal flora will be introduced inside the meninges causing meningitis. This is often in turn preceded by viral infection, which break down the normal barrier provided by mucous membrane. Once bacteria have entered the bloodstream, they enter subarachnoid space in places where the blood-brain barrier is vulnerable, such as choroid plexus. Meningitis occur in 25% of newborn with bloodstream infection due to group B streptococci. The phenomena is less common in adults. Direct contamination of the cerebrospinal fluid may arise from indwelling device, skull fracture, or infections of nasopharyngeal, nasopharynx, or nasal sinus that have formed a tract with subarachnoid space. The large-scale inflammation that occur in subarachnoid space during meningitis is not a direct result of bacterial infection, but can rather largely be attributed to response to immune system to entrance of bacteria into central nervous system. When components of the bacterial cell membrane are identified by the immune cells of the brain, They respond by releasing large amount of cytokines, hormone-like mediators that recruit other immune cells and stimulate other issues to participate in immune response. The blood-brain barrier becomes more permeable, leading to vasogenic cerebral edema. Large number of white blood cells enter CSF, causing inflammation of the meninges and leading to interstitial edema. The walls of the blood vessels themselves become inflamed, which lead to decreased blood flow, and third type of edema, cytotoxic edema. The three forms of cerebral edema all lead to an increased intracranial pressure, together with lower blood pressure often encountered in acute infection. This means that is harder for blood to enter the brain, and brain cells are deprived for oxygen and undergo apoptosis. What are the clinical signs and symptoms? Maybe this is one of the important part to concentrate. In adults, usually, patient may come to ER with severe headache. So this is the most common symptoms of meningitis. Neck rigidity or neck rigidity, inability to flex the neck forward due to increased neck muscle tone and stiffness. This is again one of the signs. The classic triad of diagnostic sign consists of neck rigidity, sudden high fever, and altered mental status. However, all three features are present in only 44 to 46% of all cases of bacterial meningitis. So it is not typical to have this pathognomonic triad in all cases of the meningitis. If none of the three signs present, meningitis is extremely unlikely. Other signs commonly associated with meningitis include photophobia, patient not tolerating to see or to have light, to see the light. It is called photophobia, or phonophobia, sorry, intolerance to loud noise. Neck stiffness, this is what you are seeing. Acute severe headache with a stiff neck and fever suggests meningitis. So lumbar puncture is recommended. Some children often do not exhibit symptoms. So maybe the children and infants, they have, we can say, atypical presentation, just to keep it in your mind. Neck rigidity occurs 70% of adult patients with meningitis, with bacterial meningitis. Other signs including positive Kernig sign or Rudzinski sign. Kernig sign is assessed with a patient lying supine with a hip and knee flexed to 90 degrees. In a patient with a positive Kernig sign, pain limit passive extension of the knee. A positive Rudzinski sign occurs when flexion of the neck causes involuntary flexion of the knee and hip. Although these signs are both commonly used to screen meningitis, the sensitivity of these tests is limited. They have very good specificity for meningitis. The signs rarely occur in other diseases. Another test known as jolt accentuation maneuver helps determine whatever meningitis is present in patient reporting fever and headache. Patient is told to rapidly rotate his or her head horizontally. If this make headache worsen, it shows meningitis. So this is again, it's definitely not a proof to have meningitis, but maybe one of the maneuvers that can be used in the physical examination to give priority of the differential diagnosis in the emergency case. This is the Kernig sign, Rudzinski sign. Also, meningitis caused by bacteria, Neisseria meningitis can be differentiated from meningitis with other causes by rapidly spreading petechial rash, which may precede the symptoms. So, if there is rash before the symptoms, may you expect Neisseria meningitis underlying cause or organism. The rash consists of numerous small, irregular purple red spots in the trunk, lower extremity, mucous membrane, conjunctiva also. The rash is typically non-balancing, blanching. The redness does not disappear when pressed with the finger. The inflammation of meninges may lead to abnormalities of the cranial nerves, a group of nerves arising from the brain stem that supply the head and neck area and control eye movement, facial muscles, and learning, among other functions. Visual symptoms and hearing loss may persist after an episode of meningitis. Inflammation of the brain, encephalitis or its blood vessels, cerebral vasculitis, as well as formation of blood clots in the vein, which is called cerebral venous thrombosis, may all lead to weakness, loss of sensation, or abnormality movement of function of the part of the body with the affected area in the brain. The most important issue to analyze the cerebrospinal fluid. So analysis of CSF or cerebrospinal fluid is critical for patients with suspected meningitis. CSF finding is different from meningitis. Types of meningitis, like for example, acute bacterial, you will find low glucose but high protein, and definitely neutrophils will be the prominent cells. Viral, normal glucose, normal to high protein, mononuclear cells observed usually. Type TB, mononuclear again, polymorph, but high protein and low glucose, fungal infection, and definitely if you go for tuberculosis stain, you will find it for bacteria, acid-fast bacilli, I mean. For fungal, you will have glucose low, high protein, less than 300 cells, malignant tissues, or hence you will find low glucose, high protein, and usually mononuclear cells. What is the initial treatment for cases of meningitis? Meningitis is usually a life-threatening condition and has a high mortality if untreated. Delay in the treatment has been associated with poorer outcome. Treatment with wide-spectrum antibiotics should not be delayed while confirmatory tests are being conducted. If meningococcal disease suspected in primary care, guidelines recommend that benzyl penicillin be administered before transfer to the hospital, if possible, of course. Intravenous fluid should be administered if patient has hypotension or went into shock, given that meningitis can cause a number of early severe complications. Regular medical review is recommended to identify these complications. Mechanical ventilation may be needed if the level of consciousness is very low. If there are signs of raised intracranial pressure, measure to monitor the pressure may be taken. This would allow the optimization of the cerebral perfusion pressure and various treatment to decrease the intracranial pressure with medication. For example, mannitol. Seizures are treated with anticonvulsant. Hydrocephalus, obstructed flow of the CSF may require insertion of temporary or long-term drainage device such as shunt. I have some videos here to have a quick summary. Please concentrate.
With meningitis, meninge refers to the meninges, which are 3 protective membranes that cover the brain and spinal cord. And itis refers to inflammation, so meningitis is an inflammation of the meninges. More specifically, it refers to inflammation of the 2 inner layers, which are called the leptomeninges. The outer layer of the meninges is the dura mater. The middle layer is the arachnoid mater, and the inner layer is the pia mater. These last two, the arachnoid and pia maters, are the leptomeninges. Between the leptomeninges, there's the subarachnoid space, which houses cerebrospinal fluid, or CSF. CSF is a clear, watery liquid which is pumped around the spinal cord and brain, cushioning them for impact and bathing them in nutrients. In 1 microliter or cubic millimeter, there are normally just a few white blood cells, up to 5. If we look at a bigger sample, like say a deciliter, then around 70% of those will be lymphocytes, 30% will be monocytes, and just a few will be polymorphonuclear cells, or PMNs, like neutrophils. That same volume will have some proteins in it as well, about 15 to 50 milligrams, as well as some glucose, about 45 to 100 milligrams, which is close to 2/3 of the glucose we'd find in the same volume of blood. The cerebrospinal fluid is held under just a little bit of pressure, below 200 millimeters of water, which is just under 15 millimeters of mercury, which is less than 1/5 of the mean arterial pressure. Now, at any given time, there's about 150 milliliters of cerebrospinal fluid in the body, and this is constantly replenished, with around 500 milliliters of new cerebrospinal fluid produced every day, and the excess, or 500 minus 150, or 350, is absorbed into the blood. But for any nutrients to enter or leave the cerebrospinal fluid, and the brain itself for that matter, they have to go through the tightly regulated blood-brain barrier. The blood-brain barrier is a special name given to the blood vessels in the brain. That's because the endothelial cells in the blood vessels are so tightly bound to one another that they prevent leakage and only allow certain molecules to slip through them. Meningitis is the inflammation of the leptomeninges, which remember are the inner 2 membranes around the brain and spinal cord. It is not the inflammation of the brain itself. That's encephalitis. But sometimes they can happen together, and when that happens, it's called meningoencephalitis. So meningitis needs some kind of trigger for the inflammation. And this could be an autoimmune disease where the body attacks itself, like lupus, or the body having an adverse reaction to some medication, which can happen with intrathecal therapy, when medication is injected directly into the cerebrospinal fluid. But by far, infection is the most common trigger for meningitis across all age groups, like with the Neisseria meningitidis bacteria or herpes simplex virus. Now, there are 2 routes that an infection can take to reach the cerebrospinal fluid and leptomeninges. The first way is direct spread, which is when a pathogen gets inside the skull or spinal column, and then penetrates the meninges, eventually ending up in the cerebrospinal fluid. Sometimes the pathogen will have come through the overlying skin or up through the nose, but it's more likely that there's an anatomical defect to blame. For example, it could be a congenital defect, like spina bifida, or an acquired one like a skull fracture, where there might be cerebrospinal fluid leaking through the sinuses. The second way is hematogenous spread, which is when a pathogen enters the bloodstream and moves through the endothelial cells in the blood vessels that make up the blood-brain barrier, and get into the cerebrospinal fluid. To do this, the pathogens typically have to bind to surface receptors on the endothelial cells in order to get across. Otherwise, they have to find areas of damage or more vulnerable spots like the choroid plexus. Once the pathogen finds a way into the cerebrospinal fluid, it can start multiplying. Soon enough, the handful of white blood cells surveilling the cerebrospinal fluid identify the pathogen and release cytokines to recruit additional immune cells. Over time, a microliter of cerebrospinal fluid might go on to contain thousands of white blood cells, but any more than 5 usually defines meningitis. In most bacterial cases, there'll be above 100 white blood cells per microliter, and more than 90% polymorphonuclear cells. In most viral cases, there'll be 10 to 1,000 white blood cells, and over 50% lymphocytes and under 20% PMNs. In most fungal cases, there'll be 10 to 500 white blood cells, with over 50% being lymphocytes. In most cases of tuberculosis meningitis, there'll be 50 to 500 white blood cells, with over 80% being lymphocytes. The additional immune cells attract more fluid to the area and start causing local destruction, as they try to control the infection. As a result, the cerebrospinal fluid pressure typically rises above 200 millimeters of water. The immune reaction also causes the glucose concentration in the cerebrospinal fluid to fall to below 2/3 of the concentration in the blood. It also makes the protein levels increase to over 50 milligrams per deciliter. When it comes to the causes of meningitis, viruses and bacteria usually cause acute meningitis, whereas fungi usually causes chronic meningitis. Now, for bacteria, there are a lot of possibilities. In newborns, the most common causes are group B streptococci, E. coli, and Listeria monocytogenes. In children and teens, the most common causes are Neisseria meningitidis and Streptococcus pneumoniae. In adults and the elderly, the most common causes are Streptococcus pneumoniae and Listeria monocytogenes. There are also tick-borne causes of meningitis, like Borrelia burgdorferi bacteria, which is the cause of Lyme disease. As for viruses, the main culprits are enteroviruses, especially Coxsackie virus, as well as herpes simplex virus. HIV is usually contracted through body fluids and can also cause viral meningitis. Less common causes include the mumps virus, varicella zoster virus, and lymphocytic choriomeningitis virus. There's also the fungi, like those from the Cryptococcus and Coccidioides genuses, which mainly affect immunocompromised individuals. And then, of course, there's tubercular meningitis, which is caused by the Mycobacterium tuberculosis bacteria. And finally, parasitic causes of meningitis like P. falciparum, which is the main cause of malaria. Now, the classic triad of meningitis symptoms are headaches, fevers, and nuchal rigidity, or neck stiffness. It can also cause photophobia, which is discomfort with bright lights, or phonophobia, which is discomfort with loud noises. Meningoencephalitis can cause an altered mental state or seizures. The diagnosis of meningitis starts with a physical exam. One maneuver is when a person lies flat on their back facing upwards, and one of their legs is raised with the knee flexed to a 90-degree angle. Then the leg is supported and slowly straightened at the knee. If this causes back pain, then it's called Koenig's sign. Another maneuver is when a person again lies flat on their back facing upwards, and then has their neck supported and flexed. If this causes them to automatically flex their knees or hips, then it's called the Brzezinski's sign. If meningitis is suspected, a lumbar puncture can be done. And this is when a needle goes through the lower lumbar vertebral levels of the spinal cord, between L3 and L4, for example. The needle penetrates into the subarachnoid space and a few milliliters of cerebrospinal fluid is taken. The opening pressure can be measured, and the cerebrospinal fluid can be analyzed for white blood cells, protein, and glucose. Polymerase chain reaction, or PCR, might also be used to find specific causes, like HIV, enteroviruses, HSV, or tuberculosis. If a particular infection seems like an obvious cause, then a test for that might be used, like the Western blot for Borrelia burgdorferi bacteria, or a thin blood smear for malaria. The treatment of meningitis depends on the underlying cause. For bacterial meningitis, it's common to administer steroids and then antibiotics to prevent massive injury to the leptomeninges from the inflammation caused as the antibiotics destroy the bacteria. In general, drug treatments like antivirals, antibacterials, antifungals, or antiparasitics are aimed at the specific cause of meningitis. Prevention with a vaccine is appropriate for some causes like Neisseria meningitidis, but also for mumps and for disseminated tuberculosis. Prophylactic antibiotics can also be administered to avoid outbreaks of bacterial meningitis, like in households where individuals haven't been vaccinated against Neisseria meningitidis. Alright, as a quick recap, meningitis is an inflammation of the leptomeninges, which is the inner two membranes that surround and protect both the brain and the spinal cord. It normally starts when a foreign substance, oftentimes bacteria, makes its way inside the leptomeninges, either by direct contact or hematogenous spread through the blood-brain barrier. The immune system responds to the antigen by flooding the subarachnoid space with white blood cells, which release cytokines and create inflammation. And this results in the classic triad of symptoms, which is headaches, fevers, and neck stiffness. Hey guys, what's up? Thanks for watching that video on meningitis. Hopefully you learned a thing or two. If you are interested in learning more about that topic, you should for sure head
Okay, I hope it was a good
over to our
summary. And because you know that the meningitis sometimes is confused with encephalitis, and it is important to recognize which is which. I have this illustrating video. It's a quick review again about encephalitis. Please concentrate.
Hi everyone, this lesson is on the signs and symptoms of encephalitis or brain inflammation. If you want more information on this condition, please check out my full lesson on this topic. Before we get into the signs and symptoms, let's talk about what encephalitis is. It is a condition involving inflammation of the brain parenchyma. So the brain tissue itself becomes inflamed in this condition. So if we actually look at the word encephalitis, itis means inflammation and encephal refers to the brain. So encephalitis means brain inflammation. Now, encephalitis may be due to a variety of causes. Some of these include viruses, which are actually the most common causes of encephalitis. So viral encephalitis is the most common. And some of these viruses include herpes simplex virus or HSV, West Nile virus, and Epstein-Barr virus. And there are many, many other viruses that can cause encephalitis. Some of these include rabies, St. Louis virus, and some other viruses like the equine viruses. Now, there are other infective organisms and other conditions that can lead to encephalitis as well, and some of these include the protozoa known as toxoplasmosis. There are metabolic conditions that can lead to encephalitis, and then there are some autoimmune conditions that can lead to encephalitis, like anti-NMDA receptor encephalitis or lupus encephalitis. Now, what is the epidemiology and risk factors for getting encephalitis? So the highest incidence of encephalitis occurs in the young and old or elderly populations. So oftentimes it can be extremes of age. And there's an increased risk in patients who have immunocompromise. So in patients who have issues with their immune system functioning, they are at an increased risk for getting encephalitis or inflammation of their brain tissue. Some of these patients include HIV positive patients or AIDS patients, organ transplant patients, and other patients as well. So these patients are at an increased risk for getting infections in general, and they're also at an increased risk for getting encephalitis from infective causes. And then another risk factor for getting encephalitis is being exposed to infective vectors in endemic areas. So if you travel to a country where there are mosquitoes that carry West Nile virus or carry dengue virus, which is another cause of encephalitis, if you're in those areas, you're more likely to get infected by those viruses and get encephalitis. Now, the topic of this lesson is that encephalitis causes a particular set of signs and symptoms. We're going to talk about each of those signs and symptoms and why they occur in the next upcoming slides. So now let's talk about the signs and symptoms of encephalitis. There are going to be some prodromal signs and symptoms of encephalitis, which are signs and symptoms that occur early on in the disease process. One of them is going to be headache. So oftentimes this headache is going to be a severe headache, and it may feel different than a normal headache. So the patient may have a sensation that this headache is not quite a normal headache. There's something different about it, and it's oftentimes, again, severe. And this is due to brain inflammation and swelling. So because of this brain inflammation and swelling, there are pain receptors that become activated due to that swelling, leading to a headache or a sensation of a headache. Myalgias are another prodromal symptom of encephalitis. So myalgias are muscle aches and pains. So this is another early symptom of encephalitis. And then malaise is also another early symptom of encephalitis. Malaise is a sensation of feeling generally unwell. And you can imagine that if there's an infection of brain tissue and there's some brain swelling, you're going to feel very unwell. So again, this is due to the state of inflammation and or infection. So whatever the infective cause might be, this can also lead the patient to feeling very unwell. Now, after those prodromal symptoms, the patient becomes more acutely ill within hours to days. So those are the first symptoms, but the following symptoms are very important to recognize as well. One of those important signs of encephalitis that occurs after those prodromal signs and symptoms is fever. So oftentimes the temperature is going to be greater than 38 degrees Celsius or greater than 100 degrees Fahrenheit by oral temperature recordings, but it's often even higher than this. It's often a high fever. And this fever can occur suddenly, and it's due to infection and inflammation of brain tissue. And then another very important symptom of encephalitis is altered mental status. This is going to be a very key symptom of encephalitis. So altered mental status may manifest as difficulty concentrating. So it can start off very vaguely. Patient feels a little off. They have difficulty concentrating. They have difficulty staying alert. Oftentimes they're going to have decreased alertness and decreased consciousness, and they're going to have some issue with confusion or altered sensorium. So they feel like they're just not quite aware of their surroundings. And you can imagine that the reason this happens is because the brain becomes inflamed and swelled. This is going to cause issues and reduction in cognitive ability. So this is the reason why we're going to see altered mental status in encephalitis. Now I have asterisks on these two signs and symptoms because these are going to be very important in recognizing encephalitis. If there's a fever, altered mental status, and a headache, and I didn't mention this before, but a headache is also important, those are going to be some classic symptoms of encephalitis. Now, because of that continuing inflammation of the brain tissue, there's going to be other cognitive disturbances that occur in encephalitis. So again, there's inflammation of the brain tissue. It's going to lead to a variety of cognitive disturbances that depend on what part of the brain is more inflamed. Some of these are going to include hallucinations, changes to temperament, behavior, mood. So oftentimes the patient's family is going to notice that their loved one is not quite the same. They're a very different person. So their personality can have some alterations and changes as well. The patient can be disoriented, so they may not know their name, where they are, or what the date is. And then there can be some general cognitive decline as well. And then there can be some memory deficits. And this more likely occurs in herpes simplex virus encephalitis. Herpes simplex virus likes to affect the temporal lobes and parts of the frontal lobes. So the temporal lobes are an area that's very important for memory functioning. So because herpes simplex virus affects the temporal lobes, we're going to see memory deficits, especially in herpes simplex virus encephalitis. Again, depending on the infective cause, we're going to see some slightly different clinical features. And one of them is, again, memory deficits with HSV encephalitis. Patients can become so bad and so severe that they can lead to seizures and coma. And in fact, seizures and coma are relatively common complications of encephalitis. This is due to brain swelling and increased intracranial pressure, or ICP. So you can imagine that the brain is swelling and there's no place for the brain to go. You have a solid cranium that the brain is encased in. So because of that increasing swelling of the brain, there's going to be increased intracranial pressure. This can cause a variety of issues, and some of them include seizures and coma. Focal neurological deficits can also occur in encephalitis patients. So inflamed tissue in particular regions of the brain can cause specific functional or neurological deficits. So if parts of the brain that are more inflamed include the frontal lobe, this may affect personality. If certain parts of the brain like Broca's area or Wernicke's area are affected, this can lead to aphasia or difficulty speaking or difficulty understanding speech. And if certain parts of the motor or sensory cortex are affected, sensation may be affected or ability to move limbs can be affected as well. So again, decreased ability to speak is one of those focal neurological deficits, and being able to use a particular limb. So this focal neurological deficit can be very similar to what happens in a stroke. So focal neurological deficits are important findings in encephalitis patients as well. And then there's some other findings that can occur depending on the infective etiology. Some infective etiologies can show up on the skin, so there can be some skin manifestations. One example is vesicles in HSV encephalitis. So if there's reactivation of herpes simplex virus and retrograde transmission to the brain causing encephalitis, there may be some vesicles on the mouth or on the lips of patients that are affected. Lymphadenopathy, so swollen tender lymph nodes, or enlarged spleen or splenomegaly may be found in Epstein-Barr virus encephalitis. And then there can be some other important motor features that can occur, including Parkinsonian features, so tremors and restlessness. They may be found in encephalitis caused by arboviruses like the West Nile virus. So there are many different other clinical features that can occur in encephalitis depending on the cause. Now, along with brain inflammation, there can be inflammation of the meninges, or the layers that cover the brain and spinal cord. So there can be signs and symptoms of meningitis. So meningitis is inflammation of the meninges. So this can lead to other signs and symptoms that can occur with encephalitis. Sometimes there may be something we call meningoencephalitis. So there can be both encephalitis, so inflammation of the brain, but also inflammation of the meninges as well, leading to meningitis. So meningoencephalitis can occur. One of the signs and symptoms that can occur if the meninges are involved, include stiff and painful neck. This is also known as nuchal rigidity. And what happens is there's a resistance to neck flexion. So in the patient, if you try to passively flex their neck, it becomes very, very difficult. You can imagine that in the brain is surrounded by these meninges, but the spinal cord is also surrounded by these meninges as well. And if they're inflamed, any bending motion can lead to irritation of the meninges in the spinal cord, causing a lot of resistance in these patients. It may be very painful or even impossible to lower the chin to the chest. And again, this is due to inflamed meninges. The inflamed meninges can activate certain nerve fibers that can cause the sensation of a stiff and painful neck. Now, there are particular clinical signs of meningitis that I want to briefly talk about here. One of them is known as Brzezinski sign. This is where there's a passive flexion of the neck that results in involuntary flexion of hips and knees. So you can see in this image here, if you had someone laying down on the table and trying to bend or flex their neck forward to try to touch their chin to their chest, the patient would also involuntarily flex their hips and knees as well. And then the other important clinical sign is called Koenig's sign. So Koenig's sign is when a patient is lying down flat, they have their hip flexed at a 90-degree angle, and the clinician tries to extend their knees. So there is resistance when the clinician tries to extend their knees when their hips are flexed at a 90-degree angle, because this can cause pressure within the spinal cord in the meninges. So this is resisted. So those are two clinical signs that can occur in meningitis that can also be found in encephalitis. So we would call this a meningoencephalitis. And some other important signs and symptoms that can occur in meningitis if the meninges are involved include nausea and vomiting. This is actually an early symptom of meningitis, and it is due to inflamed and swollen meninges and increased pressure or intracranial pressure within the central nervous system. And then photophobia and possibly phonophobia can also occur. Photophobia is a sensitivity to light, and phonophobia is a sensitivity to sound. More likely, photophobia or sensitivity to light is more likely to occur, but phonophobia can also occur as well in some cases. And this is again caused by meningeal irritation from inflamed meninges. So those are also some very important signs and symptoms of meningitis that can occur in some patients who have encephalitis. If you want to learn more about signs and symptoms of meningitis, please check out my full lesson on that topic. And if you haven't already, please like and subscribe for more lessons like this one. Thanks so much for watching, and I hope to see you next time.
So I hope that we tried to cover this important topic, and let's go now to the next topic. Try to share it. Okay, fine. Now we'll go for the pulmonology. And pulmonology, as you know, we have many acute setting or acute emergencies, and we'll try to focus on hemoptysis now. And hemoptysis or expectoration of the blood can be presented in the emergency room if the patient have a coughing with blood. Sometimes we have a term called massive hemoptysis, and massive hemoptysis is reserved for bleeding that is potentially life-threatening. It has been defined by a number of different criteria, ranging from 100 to more than 600 ml of blood over the last 24-hour period. The vascular origin of hemoptysis blood traversing the lung can arrive from either pulmonary arteries or bronchial arteries. Virtually, the entire cardiac output courses through the low pressure pulmonary arteries and arterioles en route to being oxygenated in the pulmonary capillary bed. In contrast, the bronchial arteries are under much higher systemic pressure, but carry only a small portion of the cardiac output. Despite the quantitatively smaller contribution of the bronchial circulation to pulmonary blood flow, the bronchial arteries are generally a more important source of hemoptysis than the pulmonary circulation. In addition to being perfused at higher pressure, they also supply blood to the airway and to lesions within the airways. Before assuming a lower respiratory source of the bleeding, it is important to consider whether the blood may be coming from a non-pulmonary source or origin, such as upper respiratory tract or gastrointestinal tract. The alkaline pH or the presence of pus may sometimes suggest the lungs as the primary source of the bleeding rather than the stomach. What are the major causes of massive hemoptysis? If we talk about cardiac, maybe mitral stenosis, tricuspid endocarditis, congenital heart disease, hematological disorder like coagulopathy, disseminated intravascular coagulation, thrombocytopenia, platelets dysfunction, infection like lung abscess, necrotizing pneumonia, also neoplastic causes, bronchial adenoma or bronchogenic carcinoma, traumatic like fat embolism, blunt or penetrating chest injury, systemic disease like Goodpolscher syndrome, Wigner granulomatosis, systemic lupus erythematosus also. Pulmonary causes like bronchiectasis, pulmonary embolism, cystic fibrosis, iatrogenic like bronchoscopy, vascular like aortic aneurysm, drugs like aspirin, anticoagulant medication, for example, warfarin. Also, all of these are considered causes of massive hemoptysis. The most common source of hemoptysis is airway disease. Inflammation disease like bronchitis, bronchiectasis, neoplasma like carcinoma or bronchial carcinoid, patient with AIDS, Kaposi sarcoma involving the airway and the pulmonary parenchyma, foreign body and airway trauma, fistula between a vessel and tracheobronchial tree. The infection, especially TB or tuberculosis, pneumonia, aspergilloma, lung abscess, also considered differential diagnosis. Hemoptysis, which can be life-threatening, complicate the course of 50 to 85% of patients with aspergilloma. Tuberculosis can cause massive hemoptysis through multiple mechanisms. Active cavitary or non-cavitary lung disease can cause small or large amount of bleeding. Active disease can cause sudden rupture of the aneurysm if it is there. I think this already mentioned about inflammation or immune disorder, coagulopathy, and iatrogenic. Also, some pulmonary vascular disorders, you have to keep it in mind, like pulmonary embolism, elevated pulmonary capillary pressure, like cases in mitral stenosis also. Cryptogenic, depending upon the study, up to 30% of patients with hemoptysis have no cause identified even after careful evaluation. In series of 6 to 7 patients with cryptogenic hemoptysis, the prognosis was generally good, and most patients had resolution of bleeding within 6 months of evaluation. Etiology of massive hemoptysis, as we mentioned, among the countries, I think no need to go for details, but you have to know that we have many causes. What should we do and how to evaluate? The evaluation should begin with initial history and physical examination as usual, supplemented by X-ray chest. Important features of history include age, smoking history, duration of hemoptysis, association with symptoms of acute bronchitis or acute exacerbation of chronic bronchitis. Important histological point to address, including is there history of prior lung disease, cardiac disease, renal disease, using of anticoagulant medication, cigarette smoking, patient with prior hemoptysis, pulmonary symptoms, family history of hemoptysis or brain aneurysm. Is there a history of skin rash? What is the patient travel history? Does the patient has history of abestosis, history of bleeding disorder, and if patient has any GIT disorder? Physical examination should be focused on the presence of many telangiectasias, which suggest the hereditary telangiectasia. A skin rash may be suggestive of vasculitis. A splinter hemorrhage suggests endocarditis or vasculitis. Clubbing is non-specific since it can occur in many chronic lung disease. Pulmonary hypertension may be suggested by augmented P2 in the auscultation, murmur of tricuspid regurg, or pulmonary insufficiency or a right ventricular lift. Cardiac murmur also raises the question of congenital heart disease, endocarditis with septic emboli, or when a diastolic crumble or opening snap is present, mitral stenosis. No immediate further workup is indicated for a clinical picture which may suggest carcinoma. For example, negative chest X-ray, age less than 40, no smoking history, hemoptysis less than 1 week. Is suggestive of acute bronchitis, blood streaking superimposed upon the purulent sputum. Such a patient should be treated with for bronchitis and observed. Additional study, which may be useful depending on the particular clinical situation, include hematocrit, urine analysis, blood urea, nitrogen, plasma creatinine concentration, coagulation profile, collection of sputum for cytological and microbiological study, serological test for Wegener granulomatosis, systemic lupus, or Goodpasture syndrome may be very helpful if positive. Echocardiogram may be may detect endocarditis, mitral stenosis, congenital heart disease, pulmonary hypertension. Transesophageal echogram may identify thoracic outlet aneurysm. Further evaluation indicated if the patient has risk factor for carcinoma. Bronchoscopy is the preferred next procedure. HRCT or high resolution CT scan also preferred procedure in patient at lower risk. Let's talk about the fibro-optic bronchoscopy, often considered in patients with hemoptysis and normal or non-localizing chest X-ray to rule out endobronchial malignancy, performed early in the evaluation. Risk factor predicting those individuals most likely to have tumor found in bronchoscopy, including male, gender, old patient, more than 50, smoking history as well. Arteriography, sometimes maybe if the patient continue to bleed, you have to go for arteriography study to identify which territory that may cause this hemoptysis. CT of the chest, use of early chest CT has been advocated to help localize the bleeding site and diagnose the cause of hemoptysis. The advantage of CT is that it may suggest one of the several diagnoses differential like bronchiectasis, lung abscess, mass lesion. This is aortogram. Can be used one of the maneuvers. Fiber optic bronchoscopy and HRCT in many ways complementary study, each with specific advantage in certain clinical situation. What should we do in acute management? I think this is what should we focus now. In initial priorities are ensuring adequate airway protection, ventilation, cardiovascular function, patient with poor gas exchange, rapid ongoing hemoptysis, hemodynamic instability, or severe shortness of breath should be orally intubated with a large bore endotracheal tube. Coagulation disorder should be reversed quickly. Protection of non-bleeding lung if the location or site of bleeding is known. Placing the bleeding lung in a dependent position may prevent blood spillage into the non-bleeding lung. An alternative strategy involves placement of a typical single lumen endotracheal tube into either the right or left mainstream bronchus. The approach of selective intubation is less practical when the right lung is bleeding because selective intubation of the left mainstem bronchi may be quite difficult. Left-sided double lumen endotracheal tube, this is how to go for the intubation if needed, and if left-sided double lumen endotracheal tube physically. In acute management of hemoptysis, sometimes bronchoscopy used, option for protecting non-bleeding lung with a balloon. So you will go for intubation and inflate the balloon to prevent any further bleeding of the bleeding side, involving placement of balloon catheter into segmental or subsegmental bronchi leading to bleeding side. The balloon is left inflated for 24 to 48 hours, and the patient is then observed for rebleeding with the balloon deflated for several hours. So this is how to deal with the balloon in the acute setting. Bronchoscopic technique used to slow or to stop bleeding have included lavage with iced saline and application of topical epinephrine, vasopressin, fibrinogen thrombin combination also can be used. A bronchoscopy guided topical hemostatic tamponade therapy, as you can see here in this picture. Bronchoscopy guided topical hemostatic tamponade therapy also observed. Surgery, patient with lateralized uncontrollable bleeding should be assessed for early possible surgery. The relative contraindication includes severe underlying pulmonary disease, active TB, diffuse underlying lung disease like cystic fibrosis, multifocal bronchiectasis. Morbidity and mortality are significantly greater with emergent surgery. Embolization arteriographic, also one of the options, but I think it looks there was a technical interruption. Sorry for that. So for the recommendation, first stabilize the patient and then perform early bronchoscopy. Patient continue to bleed aggressively. Arteriography is your next step. If bleeding persists, despite embolization of the patient is too ill to go for angiography, then blockage therapy can be used with a lumen tube, for example. Surgery, again, in your mind as alternative therapy. Okay. Trying to, for the next slide. Okay, it looks there is a technical issue. One moment, please. Okay, I think it's working now. I'll share with you a summarizing video. Please concentrate.
Since hemoptysis is by definition a manifestation of bleeding in the lungs, a diagnostic framework based on organ system would not really make sense here. Therefore, I'll be using one which uses the functional components of the lungs, starting with the airways. Hemoptysis can be caused by acute bronchitis, which is usually caused itself by a virus. It can be caused by bronchiectasis, which is a permanent widening of the airways, resulting in chronic infections. Hemoptysis can be caused by cancers, either primary lung or metastatic to lung, as well as aspiration of a foreign body. Moving on to the pulmonary parenchyma, there is tuberculosis, the spectrum between a necrotizing pneumonia and lung abscess, invasive pulmonary aspergillosis and chronic necrotizing aspergillosis, and parasitic infections, most classically described with Paragonymous westermanni, also known as a lung fluke, which is most commonly seen in East and Southeast Asia, though not limited to those regions, and which is most commonly transmitted to people by consumption of undercooked shellfish. In the category of pulmonary vascular conditions are both an acute pulmonary embolism and a pulmonary arteriovenous malformation. And last, there is a miscellaneous category which includes vasculitis, particularly a condition called granulomatosis with polyangiitis, and anti-glomerular basement membrane disease, also known as Goodpasture's disease. I would also consider hemoptysis in the setting of impaired hemostasis to be in this category. This includes genetic conditions such as hemophilia, as well as acquired ones such as anticoagulant therapy. However, hemostasis impairment still usually requires another trigger from this list for hemoptysis to occur. It's usually not spontaneous. But these can make a condition that typically causes mild hemoptysis to be much more severe. In developed countries, the most common causes of hemoptysis are acute bronchitis, bronchiectasis, and cancer, both primary lung and endobronchial mets. There is also a subset of patients who have so-called massive hemoptysis, which is sometimes defined as greater than 500 milliliters of expectorated blood within a 24-hour period. But of course, no one actually measures it in practice. Thus, the term massive hemoptysis is usually used to describe a degree of hemoptysis which is imminently life-threatening, irrespective of quantifiable volume. There is not great data on the relative frequencies of etiologies of massive hemoptysis, but bronchiectasis appears to be the most common. Finally, while tuberculosis and Paragonymous westermanni infections are relatively uncommon causes of hemoptysis in the developed world, massive or otherwise, they are very significant causes in the developing world. Important initial components of the history for a patient presenting with hemoptysis includes both the duration and approximate volume of hemoptysis,
keeping in mind that it's very hard for patients to accurately quantify the volume of expectorated blood. The concurrent presence of dyspnea, chest pain, rash, arthralgias, fever, night sweats or weight loss, chronic lung disease, immunosuppression, smoking history, and travel history. Vitals are always relevant, and the remainder of the physical exam should focus on pulmonary and cardiac exams, a thorough lymph node exam, and a skin exam looking for cutaneous evidence of vasculitis or a bleeding disorder. Although I excluded it from the framework due to its rarity, the presence of cutaneous telangiectasias in a patient with hemoptysis suggests the presence of hereditary hemorrhagic telangiectasia. And if, after the history, cancer or vasculitis is a consideration, a much more thorough head-to-toe exam should be performed. Key labs include a CBC, in which the white blood cell count, hemoglobin, and platelets are all quite relevant. A PTT and INR are also indicated. And all patients presenting with hemoptysis warrant a chest X-ray, unless clinical features lead you to skip right to a chest CT, which is sometimes an appropriate thing to do, particularly if cancer or a pulmonary embolism is suspected, or if the patient is a smoker who meets guideline criteria for a screening chest CT anyway. When it comes to the diagnostic algorithm, the first step is to be sure you are actually dealing with hemoptysis and not hematemesis, or vomiting blood. On one hand, that might seem like an easy distinction to make, but having encountered both of these numerous times, I can say that it actually is not always that easy, especially if the patient is only reporting the bleeding and isn't actively bleeding in front of you, or on the other hand, if the bleeding is massive, but the patient is not coherent and stable enough to provide a clear history. Let's look at some considerations when trying to distinguish between these two possibilities. Features suggestive of hemoptysis as a source of blood include no GI symptoms, known lung disease, a bright red or pink color to the blood, a liquid or clotted consistency to it, and if the sample is available, an alkaline pH. Features suggestive of hematemesis include concurrent nausea, vomiting, and abdominal pain, known gastric or liver disease, a dark red, brown, or black color of the blood, consistency like coffee grounds, and if available, an acidic pH. As an FYI, pH testing of the blood is not commonly done in practice, but can be considered if the picture is otherwise unclear. If hemoptysis is felt to be the most likely situation, then a chest X-ray is the next step, or possibly a chest CT, as mentioned a minute ago. While if hematemesis is felt to be most likely, then workup for an upper GI bleed is indicated, which may include nasogastric lavage and almost always includes an EGD. The approach to hematemesis will be the topic of a future video. Patients can also have bleeding in the nasopharynx or oropharynx that can have the potential to be mistaken for hemoptysis as well. After you've confirmed your patient has hemoptysis, if they receive a chest X-ray instead of a CT, the findings can be placed into one of three categories. First, along with consideration of the history and exam, it could show a probable infection. If so, additional workup should be based on the suspected infectious etiology. If the onset of illness was acute, that is, the overall illness, not just the hemoptysis, the patient has fever, the hemoptysis is mild in severity, and there are focal lung opacities on chest X-ray, that is all consistent with bacterial pneumonia. Additional workup is often not necessary, but blood and sputum cultures and/or urine antigen testing may be indicated in certain circumstances, such as a healthcare-associated pneumonia, severity requiring ICU admission, alcohol abuse, a failure to improve with conventional antibiotics, or the concurrent presence of a pleural effusion. On the other hand, if the onset of illness was subacute to chronic, is associated with weight loss, the patient is immunosuppressed, has relevant travel history, and the X-ray shows cavitary and/or nodular lesions, these are more consistent with mycobacterial or fungal pneumonia. Keep in mind that TB can also present with a lobar infiltrate and/or pleural effusion on chest X-ray. If TB is a consideration, the patient should be placed on respiratory isolation with serial sputum samples for AFB smear and culture. Non-tuberculous mycobacteria also require AFB smears and cultures. And if fungal pneumonia is a consideration, diagnosis is usually based on a combination of direct examination of sputum under microscopy, culturing the fungus from sputum, and testing for specific antibodies in the serum, which is best done in consultation with an infectious disease specialist or your facility's microbiology lab. And any patient falling into this category of subacute to chronic pneumonia should also have an HIV test, if not already recently done. Now, going back to the chest x-ray, if it shows a lung mass or some other finding that is not strongly suggestive of infection, the next step is a chest CT. And if the initial x-ray is normal, consider whether the patient's history is suggestive of acute bronchitis. For example, is their hemoptysis mild and from a single self-limited episode? Are there no systemic symptoms like fatigue, night sweats, or fever? And is the patient a non-smoker? If the answer to all of these questions is yes, then close observation can be considered, but this will be a minority of patients. One study found that about a quarter of patients presenting with hemoptysis due to malignancy initially had a normal chest x-ray, so have a low threshold for ordering the CT. And some clinicians would discuss with the patient the benefits and harms of a CT, even if they did meet all of the considerations for a probable benign etiology. And if the patient's history did have any high-risk features, then you should definitely get a CT. From the chest CT, as with the x-ray before it, results can be placed into several categories. First, if it shows probable infection, our algorithm merges back up to here. If it shows probable cancer, a PET scan is appropriate to see if the mass is hypermetabolic and to see if there's evidence of distant disease. These patients will also need a strategy for biopsy, either bronchoscopy for central masses, a CT-guided transcutaneous approach by interventional radiology for peripheral masses, or the biopsy of a distant hypermetabolic site identified by PET, which could both confirm cancer and confirm that it's metastatic with a single procedure. If the chest CT shows other findings, work it up as indicated, including consideration of rare etiologies. However, the most common CT finding in this category is bronchiectasis, which, depending on the patient's history and the radiographic distribution of the bronchiectasis, may or may not warrant additional workup. And last, if the chest CT is normal, it's critical to realize that malignancy has not necessarily been ruled out, depending upon how low the pretest probability of it had been. So consider following up a normal CT with bronchoscopy, and at the very least, close observation. That's an overview to an approach to hemoptysis. Key takeaway points include, as hemoptysis originates from the lungs by definition, the most logical diagnostic framework categorizes etiologies by the parts of the lungs they affect. Acute bronchitis, bronchiectasis, and cancer are the most common causes of hemoptysis in the developed world, while tuberculosis and Paragonymous westermani are significant causes of hemoptysis in the developing world. If the initial workup does not indicate a probable infectious etiology, most patients will warrant a chest CT. And last, a normal chest CT does not necessarily rule out cancer in a patient with hemoptysis, particularly if there are high-risk features present, such as a smoking history or weight loss.
Okay, thanks for listening. I think we are done, and I'm trying to look for any notice in the chat box or in Q&As.